Okay, members, we're going to commence this special council meeting here in the town hall in Enniskillen. Councillors and other contributors to the meeting will join by WebEx variously. But there's a good attendance of councillors in the chamber here in the town hall and also in the public gallery. We're welcoming local people, very motivated local people to the public gallery this evening for this very, very important discussion. And as a council, we place huge value on this meeting. So we'll have a running order here, an agenda. I'll go through the agenda, and it's a 6-point agenda. Just in relation to item 6, any urgent and relevant business. I haven't checked my emails in the last hour, but an urgent health-related matter coming from Councillor Green in respect of GP services in Brookborough Tempo, and Councillor Coyle has also indicated. Just check the room to see if that's everybody's common understanding. Okay, so apologies are first, and I go to the Sinn Féin group leader for any apologies with your group, Councillor Tommy Maguire.
I have no knowledge of any apologies.
Okay, and then I go now to Councillor Warrington, Ulster Unionist Party.
Thank you, Chair. Councillor Roy Crawford.
Okay, and then Councillor Keith Elliott on behalf of the Democratic Unionist Party.
Councillor Paul Roberts.
Thank you.
Thank you.
And then I'll check. Mary, is Councillor Garrity online?
I am indeed, Chair. Thank you very much. No apologies from the SDLP grouping tonight. Thank you.
Thank you. And then I'll go to yourself, Emmett, Councillor McAleer.
A couple of apologies from the independents. Councillor Keenan unfortunately has had to leave from the protest to go to work, and Councillor Stephen Donnelly from the Alliance Party also says his apologies due to another appointment.
Okay, thanks very much for that. And then moving on, sometimes this is relevant, declarations of interest from any councillor present. I'm looking at the chamber, there isn't any. Councillor Deehan.
Thank you, Chair. Good evening, Chair and members. I would like to declare an interest as a member of the Board of Directors of the Southwest GP Federation, apropos to any other business. And also, I would like to declare that I am the Chair of the Western Local Commissioning Group, which is a subgroup of the Strategic Planning and Performance Group. Thank you, Chair.
Thank you, Councillor Deehan. Councillor Warrington.
I'm a member of the local steering group with the LCG.
Okay. Councillor McLaughlin.
Yes, I also sit on the LCG as well.
Okay. So we've dealt with that matter, declarations of interest. Now to the really substantive part of the meeting, item 3 on your agenda, and that is to receive representatives from Save Our Acute Services, SOAS, regarding the current consultation proposals for Southwest Acute Hospital and wider concerns regarding current service provision at the hospital. So that's very substantive. Now, I have obviously a very strong delegation beside me here to my left, and I think our first speaker in the group will be Reggie. Isn't that right, Reggie? And Reggie, would you care maybe to introduce your delegation as well, you know, in your opening remarks? And then there will be other speakers, Jimmy, Aidan, Helen, John, Issam, Robert, and back to Reggie. So over to you, Reggie, to see if your speaker's on.
Press the button.
Which one is that? Is that speaker 1?
Thank you, Mr. Chairman. Reggie Ferguson's my name. I've been before you once before. It's nice to be back again, and I'd like to thank the Council and the Chairman for your invitation. I was happy to meet your Chairman at the Kingspan Stadium when he was up supporting Enniskillen recently. But So I'm glad to see him again. Now, this is a very different meeting from the 17th of November when we were here before. Nobody knew what was happening. Nobody knew what was going to happen. Unfortunately, things have taken a turn for the worse, and the ifs and buts have been replaced by certainty that the emergency services at the Southwest Acute Hospital have been removed, and it appears in the consultation programme from the Western Trust that it's very unlikely that under the Trust rule they will be back again. So that fills us with great concern. But we are not coming tonight to present a negative picture to you. We do believe in coming in person, unlike the Trust the last time, and putting our case. We must at the same time generally be conscious of the privilege we have in speaking to a democratic body, and are acutely aware of the devastation suffered by thousands, particularly in Ukraine and Turkey and Syria. So we can have no idea what they're going through, but while we will fight our case very strongly, we must keep things in context. It was very interesting. This is the council for the Fermanagh and Omagh District Council area, and in doing a bit of research, it appears to be nearly exactly the area of the old Spurn Lakeland Trust, and that will become clearer and more important later on in the presentations. And it was very interesting to read an article in the local paper by Ross Hussey, a good Omagh man, and he set things in context as to the origin of the Southwest Acute Hospital and the battle, and it was a battle, and it was fought very hard all round, and a judicial review and everything. And he basically said, look, we have no other acute hospital. As far as we're concerned, it's our hospital as well as your hospital. And if it goes, we have nowhere to go. And I thought it was a very honest, article and very timely. And there was a judicial review, and it basically came down on the side of locating the hospital where it is now, because if it hadn't been there, there would have been at least 10,000 people in this area who would have been beyond the golden hour in getting to acute services. What is proposed for this area now is that there would be 60,000 people who wouldn't be able to get within the golden hour. This council is the only democratic body we have. We are a pressure group acting on behalf of the people of this area. We are gravely concerned at the damage done by the catastrophic mismanagement of the Western Trust in delivering healthcare in this region. Now, the Southwest Acute Hospital was planned and fought for over many years and covered the old Spurn Lakeland area. The hospital itself, when it was opened, was a pride and joy to the people of this area and all who worked there. Then the Southwest Acute, the Spurn Lakeland Trust was removed because of the review of public administration, and this really has been an unmitigated disaster with a combination of incompetence and a perceived designed to do down the Southwest Acute Hospital and services in this area. It's perceived. We can't prove it, but it's perceived. I don't want to waste any further time in discussing the trust management. Save that, in my view, they should go now. And if they want to run Altnagelvin, good luck to them. And as far as I'm concerned, they're toast. What we want to do tonight is present a case for the acute services, for the retention of acute services in the Southwest Acute Hospital, giving a positive and hopeful view of what we believe is possible for medical care in this region, which includes not only the maintenance of acute services, but an expansion of acute services at Southwest Acute and playing a very positive regional role with elective services as well, and bringing down waiting lists and seeing the bigger picture, and using the fabulous facilities of from Brian Darcy's words, and he's been in many a hospital, one of the finest hospitals in this island, totally underused. Councillors, you have the privilege of representing the people of this area. I am sure you will share my conviction that we are entitled to the same services as elsewhere. I would ask you to listen carefully to what the speakers have to say, and then maybe to leave your questions until the end of the presentation. Together, yourselves, us, the people outside, the political representatives of those people, we will undoubtedly, if we stay together and fight hard, we will win this fight. Now, I would like to just set out the running order for the rest of the speakers from our group. The next speaker who will have a slide presentation is Jimmy Hamill. Then we have Aidan Campbell of the Rural Group. We have Helen Hamill. We have a medical expert, John Brown, who will be on SiteLink, as I understand, from Cork. Yeah. The next speaker will be Assam Garib, who up until relatively recently was the Director of Acute Services at the Southwest Acute Hospital. Robert Patton, a businessman who's very active in our group, will then have his presentation, and then I will finish off very briefly, and then we can have a question and answer session. So that's all I have to say. So I'd like to hand over now to Jimmy Hamill.
Okay, just before you do, Reggie, John Brown is on WebEx. Assam Garib, I don't think has joined us just yet from my indications, but hopefully will. But over to you, Jimmy.
Thank you, Chairman. Thank you, Reggie, for the words of introduction. My name is Jimmy Hamill. I'm a retired management accountant, but very active at the moment on the SOAS committee. I'm going to run through a reasonably quick data presentation that focuses on regional and local data, specifically mainly around travel time and then the other impacts. It will be heavily reliant on the slides, so if you can keep an eye on the slides as we're going up through it. We're going to go through two reports quickly. We'll just obviously do a summary of them. The first report is a report that we commissioned specifically from Ulster University in October, that we got in November. And the second report builds on the information that was received from the Ulster University report. We've then done our own detailed deep dive on information based around Fermanagh and Tyrone. The first report, called Accessibility to Type 1 EDs Across Northern Ireland, a GIS Analysis. It's a bit wordy. It was completed by Dr. Paul Mackenzie from the School of Geography and Environmental Sciences at Ulster University. It's a formal Ulster University report that has been fully and properly commissioned. He used geographic information systems to analyze hospital locations and road networks. He can then build that into a comprehensive travel analysis. We asked him to look at a scenario where SOAS is no longer a Type 1 emergency department. His main overall summary was that most Fermanagh patients will no longer be within 60 minutes of their nearest Type 1 ED as a result of SOAS being downgraded. We need to just refer briefly to an important review that was done by the Department of Health in March 2022. It was published. This is the review of urgent and emergency care in Northern Ireland. This is not the review of general surgery. that the Western Trust refer to extensively in their consultation. There was a second review done as well 3 months before that, which was the review of urgent and emergency care. Our strongest concerns are around emergency care for the Fermanagh Tyrone area. Robin Swan at the time, the main foreword, my vision for the future is to ensure that all citizens in Northern Ireland have equal access to safe, urgent and emergency care services tailored to their specific needs at the right time and in the right place. Key phrase, equal access. In the document itself, it defines the 3 types of emergency department. We're not going to go through this in detail. We're going to focus just on the type 1 emergency department definition, which is what SOAS was before the 5th of December. And that's a consultant-led service with designated accommodation for the reception of emergency care patients, that's us, providing both emergency medicine and emergency surgical services 24 hours a day. Now, we are not providing emergency surgical services at this stage in SOAS. We are stating quite categorically, SOAS is no longer a type 1 emergency department. We do not provide emergency general surgery anymore. We asked Ulster University to look at the situation as it was with the 10 type 1 EDs, including SOAS. And it's very simple, and it's very simple to state. There is nowhere in Northern Ireland at present, when SOAS was still providing it, with more than 60 minutes travel time to the nearest type 1 emergency department. Nowhere in Northern Ireland. Ulster University looked at the scenario where SOAS is not a type 1 ED. We can now state that a section of Northern Ireland is now not within 60 minutes travel time to the nearest type 1 ED. That's that corner in the bottom left there, covering Fermanagh and a section of Tyrone. Travel time now for this area is more than an hour. Now, this was the basis on which Ulster University finished their report. They were able to give us all of the small areas, they're called as part of your ward and super rapid area structure, that are outside the 60-minute travel band. We then did our own report, where we analysed this information further to get more local information. We asked 3 questions. How many people are outside this 60-minute travel time? How much longer then is the travel time to Altnagelvin? And what's the potential impact on medical outcomes because of the extra distance? So the first question, how many people are outside the 60-minute travel band? 83,343 people. Our first series of presentations focused on when people were travelling to the nearer of Altnagelvin or Craigavon. It's quite clear now that for the vast majority of cases that any redirection that's happening is to Altnagelvin. It isn't to Craigavon. So it's 83,343 people. They're all from Fermanagh and Tyrone. When we analyse those figures, that's 4.4% of the population of Northern Ireland, which makes it difficult for us to have our voice heard. That's a very small percentage. It's 100% of the population of Fermanagh. Every single person that lives in Fermanagh is now outside the 60-minute travel time to their nearest type 1 emergency department. That's 64,278 people. That's a lot of people. That's absolutely everybody in Fermanagh. In Tyrone, it's 9.7% of the Tyrone population are outside the 60-minute travel band. It's 71% of your council area. 71% of the population of Fermanagh and Omagh District Council are now outside the 60-minute travel time band to the nearest type 1 ED. You have to remember, nowhere else in Northern Ireland is asked or told to travel anything over 60 minutes. Our analysis from Ulster University shows that even if Causeway or Daisy Hill lost their type 1 ED status, they would still be within 60 minutes of either Craigavon or Antrim for Daisy Hill, or Craigavon or Ulster, or Antrim or Altnagelvin. The next question we asked was, how much longer is the travel time, okay, for the 83,343 people? At the moment, to travel to SOAS, the average travel time is 26 minutes. Travel time goes as high as 46 minutes for the Fermanagh area in Newtown Butler, or 51 minutes for the Tyrone area from 6 Mile Cross. Travelling past SOAS to Altnagelvin, average travel time increases to 107 minutes. 107 minutes, that's almost 2 hours. On average, that's an extra 81 minutes to get to Altnagelvin over the time it takes to get to SOAS. That's an extra 81 minutes. The travel time from the Newtown Butler area is 2.5 hours. And I think it's one of the most telling stats that we have is that almost 20,000 people, 19,138, are over 2 hours away from Altnagelvin. We did a breakdown, which is quite difficult to see on the slide, but we will make the presentation available to you afterwards, both by Fermanagh and by Tyrone. We can see from the figures there, the average at the bottom. The average travel time to SOAS, 23 minutes for the Fermanagh cohort. The average travel time then to Altnagelvin for those 64,000 people is 130 minutes. That's an extra 90 minutes. When you just take the Fermanagh section out, it's an extra 90 minutes on average. Okay, that goes up to as high as, you can see there, it's 105 minutes for the people from Bow, Cleenish and Letterbreen. They're very significant travel times that are not asked of anyone else at all. Okay, the question 2, how much longer is Fermanagh travel time? So very significant. How much longer is Tyrone travel time? The Tyrone factor, again, we were focused on Altnagelvin. We do accept that people from these areas may well travel to Craigavon instead, but we're working on the basis that they're part of the Western Trust demographic. This was looking at all the people in the Western Trust, okay? And so you can see there the overall figures for Tyrone, 19,000 people outside 60 minutes. The average extra travel time is 51 minutes. Okay, average travel time to Altnagelvin is 87 minutes. Still very significant. Okay. Our third question, I know there's quite a lot of information here very quickly. Are medical outcomes affected because of the extra distance traveled? We can say extra distances traveled in life-threatening emergencies leads to poorer outcomes with increased mortality and morbidity. The key here, we're talking about life-threatening emergencies. Our main concerns are around emergency cases. This is supported by a significant body of peer-reviewed medical articles and research, very significant. Average distance traveled for these people is now 55 miles is the distance they actually travel. Fermanagh people will need to travel an extra 47 miles on average. We haven't even factored in properly the roads infrastructure and the deprivation identified with this area. We look at one article when we try to assess the actual impact. The article is called "The Relationship Between Distance to Hospital and Patient Mortality in Emergencies." Okay, an observational study. 2 lines from the study, an approximate 1% absolute increase in mortality associated with each 10-kilometre increase in straight line distance. What that's saying is that for each extra 10 kilometres you travel, there's a 1% increase in the chance that you might die on the journey. The second sentence we've taken from it, this means that other things being equal, closing local EDs could result in an increase in mortality for a small number of patients with life-threatening emergencies who have to travel further as a result. The last of my slides then are taken into consideration that factor about the 1% increase in mortality for each 10 kilometres in straight line. We can then assign that to the average distances. Okay, so we can say that for all the 64,000 Fermanagh people, okay, they travel on average an extra 65 kilometres in straight line. And that means, in effect, okay, and this statement, not intending or trying to shock anybody, but this is what the facts say. 1 out of every 15 Fermanagh blue light emergencies will result in an unnecessary death due to the extra distance travelled. We're talking about the extra distance here only. That's what we're talking about. The extra distance over travelling to Altnagelvin rather than to SOAS. This goes as high as 1 in 13 for the Enniskillen area. The figure for Tyrone is 1 in 34 blue light emergencies, resulting in an unnecessary death. So there's some stark figures in that, and that brings my presentation to an end. Yeah, I'm going to pass on now to, who's next, is it?
Aidan?
Aidan, to Aidan Campbell from the Rural Community Network.
Thanks, Jimmy, and thanks, Mr. Chairman and councillors. My name is Aidan Campbell from Rural Community Network. I'm the Policy and Public Affairs Officer. And Rural Community Network, Jimmy, if you want to, to the next slide. We're an organisation based in Cookstown. We're established in 1991 as a charity. We have 250 member groups across rural Northern Ireland. And I think I know some of the councillors here from different meetings that we've been at over the years. We're here tonight, I suppose, at the invitation of the SOAS group, who we've been supporting since before Christmas. We're interested, I suppose, as an organisation in how public services are delivered and that rural communities have rights to reasonable access to services. In terms of our work on health issues, we've done lots of work in terms of responding to health consultations, looking at equality impact assessments, rural needs impact assessments. But we've also been involved for the last 6 months to a year with a range of trusts, health trusts and Department of Health officials in the development of a rural needs toolkit for health and social care. And that was launched in October 2022 by the Health Minister and by the Agriculture, Environment and Rural Affairs Minister. And the toolkit's purpose is to support duty holders, so trusts, health authorities, the department, in fulfilling their rural needs duty when designing, delivering or planning health and social care services. And I've included a link there that you can pick up on when you have access to the slides after. So just just going to talk briefly about, I suppose, community engagement and engagement around health services and the reconfiguration of health services. So the first thing we're going to talk about, I suppose, is a review of general surgery in Northern Ireland, which was published by the Health Minister in June 2022. And that sets out principles and actions for the reconfiguration of general surgery. And you can see it in the consultation that's currently being published by the Western Trust into the SOAS Emergency General Surgery withdrawal. As far as we know, there was no consultation on that document. There was no equality impact assessment and no rural needs impact assessment either. In our view, the Department of Health should have carried out equality screening to identify potential impact on Section 75 groups. If impact then had been identified, then they should have proceeded to a full equality impact assessment. And that equality impact assessment and rural needs impact assessment may have given stakeholders the opportunity to raise issues of impact on Section 75 groups in rural communities and to raise a crucial issue of equality of access to services. But as far as we know, there was no consultation undertaken. The Rural Needs Toolkit then for health and social care that we helped develop, along with trusts, partners from England and the Department of Health officials, it states that in some circumstances, acute hospital estates and their services are reconfigured, and this sometimes involves the creation of centralised specialist units. Irrespective of the merits, one challenge this brings is how to ensure acute hospitals remain accessible to those from outlying rural areas who may have long or complex or costly journeys, be they patients, visitors, carers or staff. So acute hospitals is a theme in the toolkit, and it poses key questions of duty holders that they should be asking of themselves when they're looking at the reconfiguration. So what can analysis show about travel times and transport options to acute hospital sites from settlements across the area served? What's considered a reasonable travel time? What transport options are there to acute hospitals, including from smaller or more outlying rural settlements? What are the implications for those who don't drive, who don't have access to a car, or who are too ill to drive? How far does transport service frequency limit the ability of patients to attend outpatient appointments through the day? What are typical appointment response times for ambulance and paramedic services when attending calls from rural and outlying areas? Could clinical emergency protocols take better account of rural needs where time-critical intervention is necessary, for example in stroke or heart attack? and how well distributed are resources such as ambulance bases, first responders and paramedics. So these are some of the questions that we think that the current consultation isn't addressing. The review of urgent and emergency care services in Northern Ireland, which Jimmy referenced earlier, talked about the creation of a general surgical network which will ensure that no matter where one lives in Northern Ireland, they will have equal access to high quality care, both in the emergency setting and in the elective setting. In our response to that consultation last year, we said it was difficult to see how this ambition can be achieved when no reference to accessibility is included in the clinical standards for emergency surgery in the 6 areas identified. So we raised that issue of accessibility as a crucial omission from the standards in our view. Physical distance and poor transport infrastructure, we don't think can be just wished away, especially in Fermanagh, the most rural county in Northern Ireland, most remote from other hospitals, with no motorway or dual carriageway. So moving on then to the current consultation on emergency general surgery. Firstly, the consultation has been launched after the decision has been taken. The EQIA doesn't undertake any meaningful analysis of the impact on various Section 75 groups, and you can see it. It's on the Trust website. It's page 24 in the EQIA. And consultees, and because of that, consultees are unable to make any meaningful comment, as there's no detail on that potential impact on Section 75 groups. All the consultations and strategies state that equal access is important and is a core principle, but none of them acknowledge the reality that physical distance makes access more difficult for certain people. If you don't have access to private transport, if you're a person with a disability, if you live in poverty, and if you're an older person, your access is much more difficult. So moving on to my last slide then, just in terms of the rural needs impact assessment that the current consultation has on the website. It does identify increased travel time for patients and carers and limited public transport and additional costs as impact, but it doesn't assess the impact of additional travel time on patients or outcomes. There's no analysis of ambulance response times in the Western Trust. There's no breakdown of how many patients arrive via ambulance or private transport. There's little detail on issues considered in relation to social and economic needs of people in rural areas. And the Rural Needs Impact Assessment states that rural needs have influenced the policy, but Section 5B doesn't explain how and refers mostly to the consultation process. In our view, data is key to the discussion of these issues, and very little data on the operation of emergency general surgery or the clients is contained in the Rural Needs Impact Assessment. Indeed, the support group here, the campaign group, has done quite a lot of the data and the number crunching themselves, really that the Trust should have been including, we think, in the Rural Needs Impact Assessment. The Rural Needs Impact Assessment doesn't look at the broader picture either. It doesn't identify the need for investment in transport infrastructure to facilitate access to hospital services. And it also refers, I think, in several places to creation of elective surgery centre in SOAS. And, you know, in terms of I suppose the consultation, while that might be welcome in terms of securing the future of the hospital, I'm not sure how it's relevant to the relocation of emergency general surgery, as they serve two different types of surgical need. So folks, that's the end of my slides, and I'll hand over to the next person, but happy to take questions after.
Thank you, Aidan. And it's Helen next, isn't that right? Make sure you're on.
Is that okay?
Good job. Yeah, you're ready to go.
Thank you, Barry. And can I first say thank you very much to everybody. I think the fact that we're having access to this special council meeting states how big an issue it is, and that we have a very special case that we need to make, and we're going to make that. I was going to start with a wee jibe with Barry about the OMA one, or a reminder, just the painful reminder that the fact was deemed that we have a hospital. We haven't culled that population. We still have the need. And I wanted, just before I talk on the slide, to just add current information to two of the issues that Aidan said. I have a response to a Freedom of Information request that I had submitted, and I can confidently now tell you that there was no public consultation on the review of general surgery. And in the second question, it does not have any public access consultation, therefore there will be no list of consultees. And other than that, I will try very hard to stick to not going off script. The Western Trust have been informing us, or to use a word I'm fed up of, you're assuring us, but informing is not providing evidence, and I do think we are going to provide the missing evidence. It's our right to demand equal access to safe, urgent and emergency care for every citizen in Northern Ireland. SOAS are entirely in favour of the development of an NHS-staffed, consultant-led overnight elective centre. However, we believe that a thriving elective centre will complement the delivery of sustainable urgent and emergency care. And we will call for an unequivocal commitment confirming the permanent reinstatement of full acute services to our South West Acute Hospital. We feel that there has been a deliberate lack of clarity. We feel we've had deliberate realignment of consultant resources to Altna Galvin, blatantly so, a deliberate misleading of the public and the staff on mitigations and pathways put in place, and that the Western Trust are deliberately not being open and honest with either their staff or their patients. We have heard the evolving narrative given to yourselves and to the public and on media by the Western Health and Social Care Trust, and in November they stated that it was not related to any part of the review of general surgery in Northern Ireland. On the 9th of January, they had reversed in all of their armour behind that department review of general surgery. So SOAS aim tonight to attempt to deliver honest, researched data and to get the best messages to re-emphasise to each of you councillors that the Trust hasn't been open. And we consider that based on the recent media, the Trust is still not being entirely open or honest to you. Therefore, not being honest about the compromised outcomes facing every member of the population that each of you represents. In terms of our engagement, we have actively met with all local MLAs. We are engaging and have engaged with some of the main party leaders, and we've liaised extensively with many organisations. And tonight, the fact that we're meeting with the full councillors, I think, as I said at the start, it confirms that the special case for Fermanagh is not to bed down with bigger is better, but the better outcomes must be for our lives and our existences. This slide, as far as I know, I've got my information upside down on a page, but I think that we are battling two problems. The first one is a huge geographic bias. I think we are unique. I think that the Western Trust, it covers a huge amount of the geography of Northern Ireland, but that is not a reason to be treated as less significant. I feel that there is an inclination with the narrative on occasions to say that the NHS is falling apart, Northern Ireland is below capacity, but they're omitting the fact that nowhere else outside of this region are we expecting anybody to have 5 state-of-the-art theatres, 2 of them never even commissioned, and we would reckon that the uniqueness is not being acknowledged by the population of Northern Ireland. And just a wee audio clip to reinforce.
General surgery, you will need emergency surgery. You've got a few nearby hospitals. I say nearby, I think on average about an hour's drive, isn't that right? You will need general surgery, you will need emergency surgery. You've got a few nearby hospitals. I say nearby, I think on average about an hour's drive, isn't that right?
So I don't know where William Crawley can drive from my front door in an hour, but it doesn't get near Altnagalvin. That's all I can say to that one. I think that the other problem we're battling is the more significant one. We're fighting an abject failure of management. There's a lack of ambition. There's a temporary emergency collapse of workforce and of surgery. There's a trust-wide failure in duty of care to both patient, carer and staff. There is emergency care, life-threatening illnesses or accidents which require immediate, intense treatment, which is available to every other citizen than the 84,000 that we've just factored in. So we're also asked to buy into the fact that the same workforce who is responsible for staffing this incredible failure is the same management team who would be responsible for staffing an elective centre. And I don't understand why, who, or how, quite frankly. One wee audio clip.
Can we reconfigure in the Western Trust to deliver these standards? I believe we can't. If somebody can come forward to show me a way, I'm very open to it.
And I'd like to think we will by the end of the meeting. So I think the fact that we have NIAS whistleblowers, and I know that the council have all been forwarded that information, and we have currently got Obsgyny whistleblowers speaking out because of the lack of safety. They know that their service safety is affected, and their honesty, and they're coming forward. We applaud them, and we are so grateful for them.
How could the public?
This one, sorry. I'll leave it to Neil Gulkin. But basically, the Trust is confirming so far that no safety issues have arisen since the new pathways commenced. And I don't want to ask for a show of hands, but I'm not sure that there'll be many people who could say they haven't heard of quite a few incidents since the pathways began. The next slide were the mitigations which were rolled out on the 17th of December. And I would suggest may have been rolled out, but not actually thought through. The Royal College of Obsgyny, Brendan Lavery, I think Adam suggested you had a large misconception about understanding where that was delivered, and that obstetrics and gynecologists were responsible for all sorts of emergencies. It's not, it's stroked out. Their second main mitigation and pathway was a suggestion of the extra capacity created with NIAS. And again, I do refer to both the fact that as an LGD, you are informed that before any of this crumbled, that we have significantly less than the Northern Ireland average access to NIAS. And in the whistleblower statement, we're the last ones who are going to get access. If the Greater Derry area needs are greater, the ambulances will not be sent down to South West Acute. The third one was Craigavon Area Hospital, which have had negligible, if any, admissions. Altnagalvin, assurances, bed to bed, not ED to ED. It became 2 beds, allegedly ring-fenced in Ward 31. And I do want to just interject that I heard at the weekend, because I was at SOAS ED and in SOAS ED at the weekend, I heard a patient being told by a doctor, I have got a surgeon to come, or I have a surgeon, he will look at you, are you okay to make your way up? And I looked at her because I was about a metre away, and I said, does he mean Derry? And she said yes. So I don't know who the medical expert was who was going to be in her care and in her car, but should anything happen around Scrahy, I don't know where the insurance and the mitigations cover that. I would suggest they may be on the patient's own signing out. Sligo University Hospital, it was never a go again, it was an illusion and it was never a real link. I think the suggestion was travel time may be less, and with all due respect, I think that's just a Google Map observation. So I suppose I'm saying there is no extra capacity at Altnagalvin. There is no extra capacity in NIAS. And we would be asking Altnagalvin Hospital to take an extra 27% of caseloads. And Altnagalvin Hospital cannot cope with the caseloads they have before they look in our direction. We are now a uniquely unjust population, a cohort of 83,343 patients who will not be wanted and anywhere else. And I think this is my last slide. He says with relief beside me. There's an issue of staff recruitment, which I could go into for weeks, but I won't. But staff retention is a real problem, and I think we know this. There's an unnatural rate for permanent consultants leaving posts in the Western Health and Social Care Trust. These statistics have been collated by Freedom of Information requests. We have a regional average, a normal process, I suppose, of retirements, of people relocating, of a normal fall off in numbers of about 15%. Altnagalvin has 15% of staff who have left in the last 3 years. In the same period of time, we have 40% of consultant staff leaving the southern sector or the unwanted Southwest Acute Hospital. I don't understand how that is possible. There is an accountability. There's a duty of care for staff and for patients. But if you cannot field a team, and if your team are leaving at that speed, your management has failed ingloriously, and they need to be called out on it. So this is an abject management failure that we're presenting on tonight, not a temporary collapse of anything. It has been an enforced situation which did not start in October. It just became highlighted in October. So that's me for now. Thank you very much. And I'd now like to introduce John Brown, and I can't see you, John, but I know you're on the call somewhere. There you go.
Can you hear me?
Yes, thank you.
Okay, is that loud and clear?
Yeah.
Great. Okay, will I start?
Yes, please.
Okay, John,
Okay,
proceed,
good.
please.
Great. So thanks very much to the SOAS group for inviting me to speak here tonight. My name's John Brown, and I'm a professor of health services research at University College Cork. I'm also the senior editor of BMJ Quality and Safety, which is the world's leading academic journal on issues such as the optimal configuration of emergency care services. I've been researching reconfiguration for the last 10 years. I want to make it clear from the outset that I'm speaking tonight about my understanding of the general evidence base about emergency department downgrades and not about the specific situation in Enniskillen, which I have not researched. I have 15 slides and I'll discuss my work. So next slide, please. So urgent and emergency care has been reconfigured to various degrees across the Republic of Ireland, and most of it happened between 2009 and 2013. These initiatives were done on a piecemeal regional basis rather than for the country as a whole. In 2 regions, this involved whole system integration, for example, bypass protocols for stroke, STEMI, which is a type of heart attack, and major trauma. But the largest initiative was the reduction from 39 public emergency departments to 29 emergency departments. So 10 emergency departments disappeared in the Republic. And obviously that happened of economic stress caused by the 2000.
John, we've lost sound with you for some reason. Your microphone, is there an issue with your mic presently? We were hearing you fine there just till about 10 seconds ago.
Hear me now?
No, faint, very faint. Can't hear you now at all.
I'm not sure. You just can only hear me faintly, is it?
Just faintly now. We had lost you completely there for a while. Now we're hearing you faintly.
Right. Maybe if I just speak a little bit closer, is that any better?
That's better, yep. Thank you, John.
I'll just try and speak closer to the microphone here.
Right.
Okay, so maybe just next slide, please. So here you can see the current location of emergency departments in Ireland. And it's worth noting that there are still 9 in Dublin, a city of around 1.2 million people. If you could just
We're
click
back
there.
very, very faint. We're hearing you very faintly now, John.
Okay. I'll put my mouth right next to the. I might as well turn off the video actually, because there's no point in seeing me.
That's a good idea, I think.
Yeah. So, how is the sound now?
Very good.
Okay, good. Well, it might just be my broadband. So, if you just click once there, please. Yeah. So these, the black dots show you the 10 emergency departments that were downgraded to local injury units, which are open on a limited basis, either 8 to 8 or 9 to 5. Next slide, please. So here you can see that reconfiguration was most extensive in the southern and midwestern regions of the country, where 6 smaller emergency departments were closed, largely affecting rural populations. Those regions, the Midwest, which is basically around Limerick, and the South, which is Kerry and Cork, are the regions which are suffering the worst at the moment from the trolley crisis. And the trolley crisis is notorious now in Limerick and is also chronic in Cork. And most people believe that this is as a result of the closing of smaller emergency departments in the region. Next slide, please. And unfortunately, the reconfiguration agenda is alive and well in Ireland, and there are plans to downgrade as many as 9 emergency departments. Here you can see the former head of our health service, Paul Reid, advocating for fewer emergency departments at the start of the general election in 2020. And understandably, a lot of that talk went quiet when the pandemic hit, and it became obvious how important these emergency departments were. Next slide, please. So this push to downgrade even more emergency departments is happening at a time when public healthcare services in Ireland, like the UK and Northern Ireland, are under extreme pressure. In the Republic, we have up to 1 million public patients on waiting lists and a chronic trolley problem in emergency departments, especially in the hub hospitals like Limerick and Cork for the reconfigured regions. So what you see in Limerick and Cork today is what you will see in Derry tomorrow. The situation has got so bad in the Limerick Regional Hospital that the public are sometimes advised not to attend. And one can only wonder what the residents of Clare and North Tipperary make of this, given that their emergency departments were taken away and centralised to Limerick. And this is all happening against the backdrop of rapid population growth. Our Central Statistics Office projects the population in Ireland may grow by as many as 2 million people by 2051. And this will be happening in all regions, not just Dublin. Over the next 10 years alone, there will be a need for inpatient public hospital services to increase by more than 1/3. Next slide, please. So that all brings me to the Siren research program, which I led over 10 years and was funded by the Irish Health Research Board. And the aim was basically to figure out what was the impact of all this reconfiguration. And it's a large mixed method study that produced 10 academic papers, and they're all summarized in that final paper, which was published in the Future Healthcare Journal in 2020. Next slide, please. So we interviewed 175 proposedly selected internal and external stakeholders across all regions in Ireland. The term internal stakeholder refers to doctors and managers who work in the HSE and who were involved to varying degrees in reconfiguration. External stakeholders involves a heterogeneous group of GPs, pre-hospital care providers like ambulance staff, civic groups opposed to reconfiguration, politicians and media members. And we also analysed the major Irish policy documents. And here are the main findings. First, we found, as we've heard earlier in the meeting, very little evidence of substantive engagement by planners with the public and other civic partners. So your experience is not uncommon. And this was one of the root causes of a prolonged period of conflict between health planners and campaigns to prevent hospital downgrades. So we have had all these campaigns in the south as well. Some of these were successful. So the hospital in Portlaoise, for example, still is open despite efforts to close it. And the hospital in Navan has been on the brink of being closed for years now. Others campaigns weren't as successful, and that's why we ended up with only one emergency department in the Midwest for 400,000 people. And when it came to the debate, you see internal and external stakeholders constructing their own lines of argument and to some extent arguing past each other, not with each other. So safety and efficiency were claims that were made by the internal stakeholders, who also decried the role of local politicians and tried to frame the campaigns as being about parish pump, what they call parish pump politics, and a misinformed public. External stakeholders emphasized access and the value of a fully functioning acute hospital to the life of the community, but also disputed the way that safety and efficiency were framed by internal stakeholders. At this point, I should point out that in the field of quality and safety, which is the field I work in, we all accept that there are numerous dimensions to quality, and access and equity are important dimensions of quality. And no single group has the right to say that one dimension of quality is more important than another. Next slide, please. So here are a list of questions which were brought up during the interviews, and I think are really important and show that people on the receiving end of reconfiguration have many legitimate concerns. Here's one very important one. So what you've heard a lot about at the meeting tonight is the 1% of emergency department patients who require blue light transfer and are at high risk of mortality. They're a tiny group when you look at the larger group of people who attend emergency departments. And the evidence base shows that reconfiguration is all about the 1%, but it has nothing to do with the 99%. For example, frail older people who may require repeat visits to emergency departments because of exacerbations of non-life-threatening underlying chronic conditions. And the evidence base is clear that smaller emergency departments are perfectly capable of providing high-quality care to those populations. Secondly, why is the reaction to safety incidents at large and small emergency departments so different? To the extent that it almost feels as though planners want things to go wrong at smaller hospitals to confirm their prior beliefs. Next, why is the Jenga effect, Jenga here meaning the game, of ICU and acute surgery downgrade so binary, and why are there no compromise solutions? Here, I mean the way in which many functions of an acute hospital cannot be sustained, especially emergency departments, if there is no ICU or acute surgery team on site. There are other options for providing that kind of care to people other than having one single unit or team on site. And then, of course, what about the other harms of centralization, like extra traffics on the road and the damage to the environment, the economic damage to smaller towns, the extra travel costs that have to be borne by older people and people on low incomes, ED overcrowding at the larger hubs like Outnagelvin, and obviously the disruption to local care relationships. So by that, I mean relationships between the staff in, for example, Enniskillen and local primary care providers. And more importantly, the downgrade, the local community facilities like rehab facilities or nursing homes, which the staff in places like Enniskillen will be familiar with and may not be as familiar to people in Outnagelvin. And then finally, if efficiency is important, why do we still have 9 emergency departments in Dublin, all in close proximity to each other? What other agendas, for example, the preferences of training bodies, medical professionals and medical schools about where to work and where to live are hidden from view, but strongly influencing planners? Next slide, please. So I've only 4 or 5 more slides to go. So what we found when we actually looked at the impact of reconfiguration on mortality rates was, here you can see the overall trend in case fatality ratios. And if you take the break point here as being about 2008, Now remember, when things are going down, because these are death rates, that's good news. So what you see is that in the period before reconfiguration, we had quite steep declines in mortality rates, which is good news. People were surviving these serious emergency conditions at higher rates. And then you suddenly see a break point around 2008. And since then, we have seen a much slower rate of decline in mortality. Next slide, please. And when you look at the regional results, you can see the case fatality ratios at regional level to see if the reconfigured regions had the expected improvement in survival compared to regions that did not reconfigure. Now remember, when reconfiguration is being sold to you, it's being sold as something that's going to make things better. It's not supposed to just be equivalent to the status quo. It's supposed to be better than the status quo. It's supposed to improve survival rates. And the y-axis depicts the annual percentage change in case fatality rates, and higher numbers indicate a worse trend. And as you can see, there's no obvious pattern. In fact, all three types of configuration are represented above and below the national average. The best performing region was the West, which had really only one emergency department downgrade, and still has 5 emergency departments in places like Sligo and Donegal and Galway and Mayo, for a very rural area. The worst performing region was the Southeast, which underwent no reconfiguration, but neither the Southern or Midwestern regions represented by the green dots stand out as overperformers. So Cork and Limerick have not experienced some dramatic improvement in case fatality rates as a result of having centralized all their care to 2 hospitals. And when I discussed these findings with one of the most senior people in our public health service, someone who was heavily involved in planning the reconfiguration program, they told me that these results support the case for configuration because it shows that mortality hadn't got any worse in Cork and Limerick. But when I said, I thought the whole point of reconfiguration was to increase survival because small hospitals like Enniskillen are supposed to be so dangerous, they said, no, it's got nothing to do with that, really. It's because nobody wants to work in these hospitals. And that opened my eyes to the way that research findings can be framed and weaponized in this field. Next slide, please. And here's another example of this problem, which I think is very pertinent to your situation, this time using research conducted by colleagues in the RCSI. And the study found that there was no difference in survival rates for emergency abdominal surgery between low, medium, and high volume hospitals in Ireland. And in fact, if you look at the last column, the survival rates are almost identical. But look at how this study was interpreted. So if you could just click once, please. Here's one of the authors of the paper, Ken Mealy, who works at the RCSI. And this is a direct quote from a newspaper interview where he says this study, which shows that low volume hospitals are just as good as high volume hospitals, shows that we need to reduce the number of hospitals. Now, I'm not going to say any more, but I don't think that that is a fair interpretation of the results. The results show that there is no correlation here between the size of a hospital or the size of a surgical team and outcome. So moving to finish up then, if we could just go to the next slide. So to summarize the research I've done, it's obviously a complicated, contested policy arena. The terms of engagement are not clear. When the terms of engagement are not clear in a situation like this, there's a real danger that people try and pull the expert card and they just tell you, well, listen, you don't really know what you're talking about. I'm a professor, I'm a doctor, just do what you're told, listen to the experts. But this isn't an area where the experts agree. This is a contested area. Evidence plays a confusing role, especially the volume outcome literature, and it's not clear what the rules of the game are, and the goalposts keep changing. There was no evidence in Ireland that reconfiguration improved outcomes. Now, the research is obviously not perfect to test this hypothesis, and lots of other moving parts are in play. But if someone comes to you and says, the evidence is clear, we have to do X, then I don't think that that is a correct way to interpret the evidence base. The mortality evidence does not point in one direction, and policy solutions are not obvious. And this is my final slide. So here's the things I've learned from the work I've done. So first of all, you have to understand, I think if you want to do some research in this area, that the evidence rarely maps perfectly to every context. So if someone comes to you and says, well, look at this research from England, from London, from America, from Australia, it's very unlikely it directly maps to Fermanagh. We need to accept multiple perspectives on purpose, success, and failure, and that involves proper consultation. Understand that all evidence is framed, and there is no perfect frame. There's no perfect answer to these problems. And realize that it's dangerous when powerful interests do all the framing, because they'll do it inevitably because of human nature, because of their own vested interests. And I do think we should make a sustained commitment to working on these complex questions. And then finally, the don'ts. Don't start with lazy stereotypes about urban always being superior to rural, or big always being superior to small. Don't let the tail wag the dog here. Here what I mean by that is don't focus only on the most severe patients or only on medical workforce preferences. Don't change the goalposts when the findings are annoying. Don't buy the hype about the success of top-down restructuring plans delivering economies of scale or avoidable admissions. Any gains you see are likely to be drowned out very quickly by population growth and population aging. And finally, don't overgeneralize your conclusions and dismiss the importance of place. Place is very important, and there are unique places on this island like Fermanagh. Instead, you're better off treating each investigation as a case study. Okay, that's all. Thank you for listening.
Thank you very much, Joe. Reggie, do you want to maybe help introduce Sam, maybe? That'd be a good thing to do. Yeah, go ahead, just press away. Yep.
Yeah, I'd like to introduce the next speaker, Sam Garib, who would need no introduction to many people in this area who have benefited from his skill as a doctor, a consultant, and a great supporter of the Old Erne Hospital. And he was, I understand, the director of surgery at the Southwest Acute Hospital. And I would say he's a person who is very well placed to comment on the present goings on. And I'm glad to see him looking so well.
Thank you. That's lovely. Thanks very much for this lovely introduction. I didn't expect that. My presentation really is related to historical facts, okay? And because being involved in the Erin Hospital and the joining of acute surgical services between Tyrone County Hospital and the Erin Hospital, and then moving to the new SOAS hospital. So I know what has been happening over the years. So it is a historical, actually, historical comments about what has been happening. So next slide, please. So the trust always says the problem of recruitment. They can't recruit doctors to come and work in Fermanagh. And why is that? Because they have chose to ignore the changes which is happening in surgical training. We highlighted that to them very clearly, and I highlighted to the Department of Health, myself and a colleague of mine who was the director of anesthesia, to the chief executive of the trust. And we told them that, and that was even before the final decision to build SOAS. And we told them that this changing trends, we will actually, if we continue to ask for surgeons who are not there, we are not going to get them. There is nothing called the general surgeon anymore. That was the old days. That was like my days when we had surgeons who spent 12 years, 14 years in training through many specialties. And then we can work while we have a specialty, but we can work on other specialties. That was finishing, and we highlighted that very clearly to them, right? That its specialization is coming, and that's why we have to change and we have to adapt if we are going to continue to keep the hospital running. So there was a failure to upgrade the surgical services in SOAS. What we were trying to do, we asked them very clearly to have specialties, surgical specialties in SOAS. And one of the specialties which I actually talked about a long time ago is bariatric surgery. And we could have provided bariatric surgery for the whole Northern Ireland, to run. And now in the hospital, there is one of the surgeons who's trained in bariatric surgery, and he's not doing it. The other specialty is colorectal surgery, and the hospital will need at least 3 consultants, plus 4 consultants in bariatric surgery. That number of 7 should provide easily the rota. If you provide these specialties in the hospital, and I must tell you that it is a very attractive, Fermanagh and Tyrone, they're a very attractive place to work in. Because I talked to many of the new generations of surgeons, and they have no problem at all, but they can't come. How they come when they provide the same advertisements for jobs which nobody can fill? Next slide, please. So it boils down that we have incompetent management in the trust, okay? They have resisted the suggested changes we asked them to do. They continuously undermined the Erin Hospital and then SOAS, and they started taking the specialties very slowly, one by one. And if you take as an example, breast surgery, and it goes well with what Professor Brown was talking about. They talk about the evidence. With breast surgery, I was talking about, they talk about surgery. At that time, I'm talking about over 25 years ago. There were 2, they came up with saying that it's one stop. Same, it could have been.
He has done that.
Sorry. And it could have been done in the Erin Hospital. Sorry.
Sam, you're fading a wee bit.
Sam, we're just struggling to hear you in about half minute or so, but it might be a solution for you to turn off your camera if you can do that. Might assist you, I'm advised.
Yeah. Okay. It's just my internet connection is not great here. So as an example, as I'm talking about is breast surgery. It didn't have to go to Altnagalvan Hospital, but they, at that time, there was an insistence that we have to take the surgeon who was in the Erin Hospital providing that service to go to do the job there in Altnagalvan. And there are a lot of details which this meeting is not the place to talk about the details, what happened, details which this meeting is not the place to, or they kept that specialty there, and we lost it. Okay, now that happened in other things as well. So there was actually this plan which was very clear that at the end, all the acute services will go to Altnagalvan. This is inside information from all the clinicians who work in our hospital. We know that this was the plan, and some of us resisted that plan, but unfortunately, we never had the management which would support us to stand up and stop this nibbling all the time in the services in our region. So the whole idea of, if you look at what happened with the doctors, the locums who came to the hospital, and the surgeons who came to the hospital and they left, there was how can you have a surgeon who can't have any complication? There is nothing called surgery without complications. Any complication happens, there is a major incident is done, and and it is well known that complication happens in the Royal Victoria Hospital. It's a well-known complication, and there is no hassle. But they made hassles for the locums and all that, so people couldn't continue to work, and that's why you have a problem in getting them or keeping them. And regarding locums again, if you want to get locums, they are well known, and I did as my position clinician and the director, we can get them supported. They are coming to a new environment. We support them, we stand beside them till they are happy, and they build the confidence in the place and the people helping them, and they continue. And many of those locums, they can after that be in a permanent post. But it's always, there was that policy of degrading and threatening to those people that they couldn't continue. And all that, it's a well-known tactics which happens in the health service when you want to make changes like what they're trying to do now, is to create a crisis. And you say, well, look, what can I do? We have to close the services. Next slide, please. Now, when we look at the plans, I looked at the different presentations from the trust, to say that this is our great plan to compensate you and make you happy with the new center they're talking about, which is actually, the SOAS was built to be for Northern Ireland as the center for non-acute cases. That was the plan from the beginning anyway. So there is no addition to that, and that is not going to make anybody happy anyway. But they talked in their presentations about emergency surgery, cholecystitis and this and that, but they never talked about the cases we see where somebody's bleeding, where somebody had to be operated on in an emergency department. Not even like there was no time to go up to theaters. So where are we going to send those? 2 hours at Nagalvan. Those people who are, my colleagues there, they talked about the 84,000 people. And for those people, the SOAS was built. That's why it wasn't built in Omagh. It was built there because of those people. So, and those are the real urgent. There is something called the urgent surgery, where you stop bleeding. How many times did we have, myself and colleagues, had to rush to the hospital in 10 minutes to stop bleeding, to look after this urgent cases come from somebody hit by a cow, somebody hit by a tractor, somebody lost his arm, somebody this. And it's enough for them that they had spent half an hour drive coming to the hospital. I can't see anybody talking about those people. Now, they are talking about they're going to maintain this emergency or acute, or the center, the acute center in the hospital from 9 to 5. And it is going to run by the middle grade doctors as well. There is no middle grade doctor will keep a job just only to look at those patients like that without attending surgery and theaters and the clinics. None of, it's very rare to find somebody. And if you have those people now, they're definitely going to leave. Those people, they are surgeons. They won't attend attend the theaters, they want to attend the clinics. They want to learn from the consultants working with them. You know, so it is not going to happen that you will be able to maintain them working there, you know, for just to look at patients like like they're just like physicians, you know. And I'm not saying anything about but you know, this is not the full job, so they are not going to continue. Now, when we come to emergency department doctors and the middle degree doctors, they need consultant surgeons on site, you know, to see patients. You know, you know, I don't know. Those are things which are very clear to any surgeon, and I don't know how could they, you know, or how were they be able to write something like what they wrote, that, oh yes, he will ring a surgeon who is, you know, 60 or 70 miles away. You know, that doesn't happen. We have to be on site, consultant surgeon, to take responsibility of the case. We have to be on site straight away to see the patients. Not all the problems can be sorted by ringing somebody and just ask their opinion. And I noticed as well in their presentations that they were talking about, we will, this is a temporary situation, and they will try to recruit consultants. You know, if we come to the recruiting the consultants, are they going to advertise the same way they have been advertising all the time? Just the general surgeon? They are not going to get that, and they know they are not going to get that. So there is an immense failure from the management side to sort the problem. And it goes down to actually, it's a planned failure, you know. So because they were told many, many times, this is not going to happen. And it happened many times that you advertise and you don't get anybody. So I would like to see, for them to show us, you know, when they were discussing the problem of recruiting consultants and keeping them in the hospital, you know, show us, what did you discuss? How can you sort the problem? You know, I can't see anything at all, because the answer to my question is that it comes out in the ads they are putting, the same ads all the time to recruit. So in my opinion, you know, and from my experience, I know that this is a planned process, and I knew that it would come to this stage. And it's not a failure from the trust management only. It's really a failure from the Department of Health and the NHS as a whole. And I have a lot of doubts that it's going to survive. But the main thing here, that we have to look at the population, which we served for many years. It is completely unfair that that this service will be taken from them, because it is completely unacceptable. Thank you.
Okay, thank you.
Sorry, there is a slide here. Can I talk about this slide quickly?
Yep.
You know, from my meeting with the members of the group, you know, if we have a problem, or if I'm presenting a problem, you can't present it without a solution. And the solution, as I see it, that it has to be stated very clearly from the Department of Health that SOAS is to stay as an acute hospital. Because in my opinion, that will stop all this games that the trust is playing to downgrade it and to take all the service from it. If that's done, so it will be finished. And that was done previously, but changing the trusts and changing the systems all the time, obviously, they forget what was said. So as I said before in my presentation, we have to create surgical specialties. And I think bariatric surgery is a solution for the problem, and the colorectal surgery to continue and to be strengthened in SWA hospital. That will provide at least 7 consultants, which will provide a very good rota for any consultant coming. Now, to recruit, we don't have to look into Northern Ireland only. It has to be a nationwide process to recruit the permanent consultants, and international, especially for the locum jobs. You know, we traveled to Poland, we interviewed people, and we got excellent doctors who are, some of them still working in the hospital. You know, so that's the real effort to recruit surgeons. You can recruit the locums till we have these specialties manned properly, and we have a good road. Thank you.
Okay, thank you. Reggie, do you want to?
Yeah, thank you very much, Sam. And I had said earlier there was a perceived approach by the Western Trust to downgrade the Southwest. Well, I think I can remove that word perceived, because Sam Garib has just set out exactly what is going on and has gone on, and he speaks from experience. The next, and thank you very much for your efforts and your effort to give us the benefit of your wisdom tonight. And I hope we will speak to you again many times. And the next speaker is Robert Patton, who has extensive business interests in the south of Fermanagh and in Monaghan. And he is, I think, going to set out, leading on from what Sam said about the possibilities of change and improvement.
Thank you, Mr. Chairman, for the opportunity to come before the Council. My name is Robert Patton. By way of background, I've been in business all my life, and I continue as non-executive chairman of a company with a staff complement of about 130 people. I've lived in South County Fermanagh for the last kind of 35 years. And in relation to travel time, I can tell you that we in our area need to allow 2.5 hours door to door to Altnagelvin. Okay, so let's recap where we are. The Western Trust, which administers SWA, has chosen to discontinue acute services. Why? Because they cannot employ sufficient consultants to satisfy patient safety standards. But in so doing, the Trust is actually putting patients at risk by requiring them to travel to Altnagelvin. So on the one hand, they invoke patient safety as the reason for cutting the service, while at the same time they increase the risk of mortality on the other. How can this contradictory policy be called acceptable? How did it come to this? The guiding principle of a hospital trust should be the continued provision of care for the people it serves. So to cite insufficient surgical cover is not an excuse to abandon its central obligation. Inability to recruit is quoted as the cause of this crisis, but it's not just recruitment. It appears that management have been unable to retain those they actually have recruited. Available data that was presented a few moments ago shows that the average leavers per year in NH hospital is around 14 to 15%. Yet in the SWA, it's almost 40%. Why then, if it appears so difficult to recruit consultants, is the Trust so relaxed about retaining them? What is driving this higher leaving rate, 3 times higher than the average? It's clear that something is seriously wrong, because it's patently obvious that it's easier to retain good people than it is to find them. Now, we can't know the circumstances of every individual, but we do know that excessive leavers combined with the low morale among staff points to poor management. In fact, It smacks of an attitude bordering on complacent at best and hostile at worst. Today, post-Brexit and post-COVID, good people are harder to find and they take more effort to keep. But if we're unable to fill posts, do we just throw up our hands and say, well, let's just cut the activity out altogether? No. We double up, we try harder, we change the offers, we look for ways to make it more attractive. In summary, we do whatever it takes. In that context, we're aware that there is a 10% to 30% salary top-up available under the Rural Retention Premium Scheme. And yet, we find that last November was the first time the Trust looked to use it. And once in post, it's management's responsibility to look after its people, not simply just to hope for the best. The case of Surgeon Mr. Rafael Sopulo is notable in this context. An award-winning surgeon, he was employed by the SOAS, but he left after only 7 months. In that time, he was prevented from operating while his colleagues took his place. Where was the management during these times? Now, this surgeon and others have indicated willingness to come back to Enniskillen, but not under present circumstances. So we don't buy the argument that consultants don't want to come here. After all, we have in our hospital a fantastic resource designed from scratch, well laid out for the disease challenges of the future. The most modern on this island and one of the very few conceived and built in one piece. Now, you councillors may agree with us that in the past few years, the Trust has been anything but transparent. It has issued a stream of contradictory announcements. It has not been open to you and is often at odds with its actions. It's hard, therefore, to avoid the conclusion that patients in the southern part of its geography are lower priority than elsewhere, and so are not provided with the equal access mandate required by SWAN. It's now clear that the tenure of the Western Trust in charge of SOAS has run its course. You councillors have recognised this already in voting no confidence in the governance of the Trust. From this evening's presentations, you've seen that people of Fermanagh and Omagh district are out on a geographical limb. Armagh, Down, Antrim, Derry have easy access to all services. So by virtue of our geography, we are a special case. And so a new model is needed. The SOAS should now be totally separated from the Western Trust in either a new standalone trust or an alternative structure. Its remit will be to serve not only local needs, but regional needs as well. New SOAS will have its own board composed of individuals from our region, including serving doctors. It will recruit its own consultants and all other staff. And by the way, the rural retention premium will be extremely valuable incentive. It'll be accountable to the community it serves. It'll be, and it will appoint its own chief executive. It'll provide not only the medical services needed in the area, including acute services, but also those specialties which can be better provided in Enniskillen, thus freeing up capacity elsewhere. SOAS has 5 operating theatres. As we've heard, 2 of these are still not commissioned. In the face of such long waiting lists across Northern Ireland, it seems a totally wasted resource, but also an opportunity. Elective surgery will be also a significant and essential part of SOAS responsibilities, offering treatments across Northern Ireland and further afield. The resumption of teaching will also be on the agenda. Once SOAS is unlocked from the dead hand of the Western Trust, many new opportunities can open up. Right now, our group will be engaging with the leaders of all political parties, and so far we have enthusiastic feedback on early discussions. But you, council members, are needed to play a vital part by supporting this vision. And importantly, making your support clear to the public and to your party leaders. We have confidence that with your backing and with our MLAs on board, the future of this hospital will be brighter than ever. Yes, there may be obstacles, but the logic of what we have heard this evening is inescapable. In embarking on a new path, the SOAS can grow and develop its activities, skills and career opportunities, as well as securing employment for the 1,000 odd people who depend on it. Some of them are outside these doors tonight, waiting for a signal that change is on the way and that we are set on a new path. Ladies and gentlemen, councillors, let tonight be the first step. Thank you.
Yeah. Do you want to conclude?
Thank you, Robert, for that very well-researched and optimistic position. I don't have an awful lot to say. I'll just that's the end of our presentation as far as the speakers are concerned, and you've heard from people from all across the spectrum, particularly from the medical expertise which we were able to get this evening, particularly from Sam Grieve, who has been there, done that, has worked very hard for the people of this area over many years. And you see the difficulties he has had with the management and the change. I mean, I don't think the management probably could have done any better. I just think the management is incompetent. I think that the day and hour that the Spur Lakeland Trust was done away with and we came onto the Western Trust, we haven't done well. We have the powers that be in the Western Trust have run it as they've always run things around Derry. They don't see why it should be any different. As Sam Grieve said, they're trying to create a Royal Victoria Hospital in the West. That's not going to happen. Their interests aren't our interests. We wish them well in their own area. But as Robert says, we must give some serious thinking to creating a new trust, possibly for the area that the council covers, as it was before. It'll not be easy. It will involve the Department of Health being put on the spot, being challenged, being asked to consider these things. And you know, in Northern Ireland, things change very slowly because of the special interest groups. But we would hope that from tonight on, that our positive message will be heard both by the council and the public in general, and that the whole there are an awful lot of things need to be looked at, including the training of medical people in Northern Ireland, the development of the graduate medical school in Derry, what's happening there. We train more doctors, we get them to commit to local area, have a commitment to where they're from, and you know, we look at if you need general surgeons, if you need emergency surgeons, why not go back to the medical schools and say, this is what we need. You're training some of the people we don't need. So that's something to be looked at. We have to be creative. We hope that we just feel that the Western Trust has run out of road and we have to replace it. And there are positive messages coming out from tonight, that things can be brighter, that the hospital can thrive in the future, and there are all sorts of possibilities for the wonderful building that it is. And I would ask you to take all on board, and you have sat quietly for an hour and 3/4, and we thank you for that. That mustn't have been easy for councillors who all like to talk and ask questions. And
Not too bad at it yourself.
so now, if through the chair, if anybody wants to ask a question,
No problem.
Thank you very much again.
Okay, thanks. And obviously the status of the delegation is important to us, and that's why we afforded so much time. Very, very important debate, very, very important subject. So, councillors on WebEx and councillors in the chamber, please indicate if you wish to speak. First to do so is Councillor Warrington.
Thank you, Chair, and thank you very much to the panel for their contribution tonight. I have to say it was all very good, and especially the contribution at the end there from Mr. Patton was very uplifting, and Mr. Garib's, I call him Mr. Garib because I've been on the slab in front of him, so I'm going to be very nice to him. But it has all been very good. I'll start off by saying, like we all know that the SOAS is a state-of-the-art hospital that has, from the day and hour that the doors opened, has never been used to its full potential. We're sitting, which has already been alluded to tonight, with 2 theatres that hasn't even been commissioned. And we talk about the elective surgery and emergency surgery. The SOAS can accommodate both easily. The trust giving us the elective surgery, let's be honest, that was a fig leaf to try to take away from what they were doing with the emergency surgery. So, you know, there's so much more to do there. I have 2 questions, and I think Mr. Grieve is still here, so maybe he will mention one of them.
And Mr. Victor, because of time, I'm going to take 3 speakers at a time with their contributions, you know, and their questions. So if Mr. Garib and other speakers could just figure that out in terms of giving a composite response to 3 speakers at a time.
Okay, well, okay. So I've said this before. I think part of the problem with the trust is we're sitting with directors that are not from a medical background. And I think it would be a great benefit if some of the directors on the trust was from a medical background. But we have the chief executive who's an accountant. And is he looking at how we move forward from a financial perspective of how you make this pay or whatever? And that's, you know, that's not right. If we had individuals, and this is just putting it out there, like Mr. Garib on our trust, I think it'd be a lot better managed. And my final question was, again, which will probably have to be answered by somebody medical, is the golden hour. I sat in a meeting of our health committee during the week, and we were told that the golden hour didn't exist, that it's a myth, that it's not there. And to a degree, I disagree with that. And it certainly would be good to get a focus from some of the medical people if the golden hour is important. We know how important it was with strokes. And I know a friend who had a massive heart attack during the week and landed into SOAS. And when he went in, he collapsed again. And the attention which he got saved his life. And so those questions, please, whenever that can be answered. Thank you, Chair.
Thank you. Just take 3 speakers at a time from the councillor cohort. So Councillor Green is next, then Councillor Deehan on WebEx.
Thank you, Chair, and thanks everyone for the very informative presentations. It's one thing about going to rallies and that, but it's another thing coming and sitting, as you said there, for an hour and 3/4 and listening to all the analysis. It really is eye-opening and food for thought. So I commend everyone there that gave a presentation. The Western Trust, I believe, are a wee bit like a football management team that has led their team to 20 years of failure. But
next season will be different, but it never is. So just for that comment. The other one I was going to mention about the golden hour. All of a sudden, it doesn't matter when it suits them. I was looking back a few years ago when the golden hour was crucial, but now it doesn't matter because, you know, it's further than an hour away to Alton-Galvin. It seems extremely strange that the way that medicine can change within a couple of years to suit the narrative at the time. The other thing that I noticed in 1995, and this probably is going to the what I think it was John Brown from Cork there was talking about. In 1995, there was 19 acute hospitals across the north. In 2023, I believe that's down to 10. And I don't believe that anybody is suggesting that medical care is better now because we've went down to 10. So it's not really a question in there, but just damn few comments.
Thank you. And Councillor Deehan.
Thank you, Chair. At the outset, I want to thank SOAS for coming to Council tonight. I want to really express my admiration for your energy, your dedication, and the strength of your campaign. And each and every one of your contributors really raised very, very important points. And I want to assure you that as a NOMA councillor, I am 100% behind your campaign to save acute surgical services in the South West Acute Hospital. As Councillor Michael Duff, our chair, will know, I was very actively involved in the campaign to save acute services in Tyrone County Hospital. And at that time, as Helen said in her report, the golden hour was paramount. We even tested this out in practice. The recently deceased journalist Henry MacDonald and I and a mock patient travelled from McCullough's in Greencastle to the then Erne Hospital to see if it would be within the golden hour, and it was. And it was because of the fact that so many Fermanagh patients would not be able to access acute services in that hour that we lost what we thought was a very good case. It was a bitter pill to swallow then 20 years ago, but we have moved on. Now, my question really is, and a lot of the focus this evening, Chair, has been on the Western Trust and the way they have handled recruitment, retention of staff. And I accept that is a very good argument to make. But my question really is, what does the campaign feel about the fact that what we're seeing in Enniskillen may be the outworkings of what is known as the Bengoa report, systems not structures, changes to health and social care, because many people would argue that not every acute hospital can be retained. I believe we need an acute hospital in Enniskillen because of our geography and because of our very poor infrastructure. So that's my first point, my first question. And secondly, I want to ask about clinical interdependencies, particularly interventional radiology and other specialties as well. This is another argument that the Trust makes why it cannot sustain acute surgical services. So I would like a comment on that. And finally, I just want to make a point, and it's relevant, Chair, to our any other business, the crisis that is facing primary care in our district council area as we speak. And just to say that I am a practicing general practitioner and I am very concerned regarding any threat to acute services in the South West Acute Hospital, because it will reduce the ability of general practices to attract young doctors into the profession if they feel they don't have the hospital services to support patient care. But very well done. Thank you. I've really enjoyed your presentation and good luck. Thank you, Chair.
Okay, so I have three councillors who made comments variously and who asked some questions. and I'll maybe take me direction from Reggie as to who within the panel will address the issues raised by the three councillors.
There were some medical/clinical matters which were raised. I wonder would Sam Grieve, if he's still with us, we have someone who would handle the question about the Bengoa report, but I wonder would Sam Grieve
still here, yeah,
take the medical clinical questions?
Yes, I'll try to remember exactly what was said. The first thing about the golden hour, you're absolutely right. Where did it go, the golden hour they were talking about just a few years ago? This is a medical thing. They like to change the names of things, but it is still the same thing. All right? That's why I didn't say the golden hour in my presentation. I said urgent cases. Urgent cases, if you change a golden hour or make it silver or whatever you like to make it, still there are urgent cases needs to be dealt with immediately. So this is the point. So forget about the golden hours, but we have urgent cases. You know, cases of bleeding, cases of an accident, of farm accidents, which those people in Belfast, they don't know anything about. So this is about the golden hour. The interdependencies, as Dr. Dehan was saying, I'll take it from maybe a different view. They are talking about maintaining Gaia and Ops service, and then maintaining Gaia that there are 6 consultants, and they're going to, and you know, the experience, there is no consultant, gynae and ops, going to work in the SWAT hospital if there is no surgeon on call. Because those people in the trust, they don't know what happens in theaters. How many times was I called to theater to help my colleagues, consultant gynecologists? So it's going to be finished. If we remember what happened when the acute surgical services left Tyrone County, the medical services closed straight away, while we provided the presence of consultants every day in the arrangement we made. But still, because the physicians didn't like to work without the presence of a consultant surgeon. So what I'm saying to you now, this is just only the first step of completely making the hospital just like a nursing home. Is there any other point, Reggie, I missed?
That's the medical and clinical issues covered and addressed, we believe. So somebody from within the team will address the Bengoa point.
I think Helen will take up that query.
I think I'm the perfect one to take that up because I'm apolitical. I'm not even politically correct, and I think everybody who knows me knows that. I think Bengoa was a suggestion. It wasn't a prescription. I've been involved in health activism since John Compton began transforming care. So I think there's an awful lot of transforming and reforming and not enough performing surgery, to be perfectly honest. In the narrative we've had at the moment, when we've listened to the bigger is better outcomes, I'm doing that with documents beside me all day, every day since October, except for 4 days off at Christmas. Robin Swan wrote the document from a Bengoa framework, and he left his office pointing out that our hospital did not meet any criteria that he had set. It had not given any, it hadn't left any stone unturned in its ongoing recruitment. And this was a plan to see that every square inch of the hospital was used. And I'm just going to quote what we've heard from all of the political parties when we've met with them as SOAS. One size does not fit all. That came from both the Ulster Unionists we've spoken to and the DUP. No area should lose out due to transformation It may mean reconfiguration, but it doesn't mean a loss of service. That's an SDLP one. And Sinn Féin, stop conflating two issues. This is not transformation, and a collapse of service is never acceptable. So I would say that, Josephine, when you refer to the clinical interdependencies, I have read them inside and outside and roundabout. And I had an email contact actually from the Department of Health today. And to be honest, as I said, not every hospital and not any hospital in Northern Ireland has the perfect setup, I'm told. So therefore, I'm sticking by the illusion that we are entitled to equally. We are entitled to the right care first time in the right place. And I would contest that with the removal of emergency access and emergency and urgent care are time limited, whatever you choose to call them. But 2.5 hours up a road to a hospital that may not even want to receive you is not a fair outcome.
Okay, thank you. Now, members in the chamber itself, there's around 10 councillors who have indicated they wish to speak. So you do know that beyond 9:30, we'll have to deal with 2 other matters, but we're going to try to time manage and get everybody in. So we're going to take them in sequences of 3, and the next Corleor councillor is Corleor O'Coffey. Donald?
Yeah, thanks, Chair, and thanks to the SOAS which is presented there tonight. I think it's very important that we have people in our community, health activists, those who turned out for tonight's SNAP rally before the meeting, and indeed many of the nurses and healthcare workers that was on picket lines this morning outside SOAS are all looking to this campaign with hope and expectation. And there's a great responsibility, obviously, on this council to deliver. We're the only democratically accountable form of government we have in Northern Ireland at this moment in time. And we have to defend and step forward to defend our community. There's so much in tonight's presentations that were very informative, and I would find a lot that I certainly agreed with. And in particular, I want to highly commend Professor Brown's presentation, which criticised very rigorously the logic of reconfiguration and the fact that it's being driven by and framed by vested interests. And I would also add that this is a private sector driven agenda as well. The fact remains that 84,000 people will be outside of the golden hour as a result of the proposed removal of emergency general surgery. That's every single person in Fermanagh and almost 10% of Tyrone. That's dreadful. I want to agree with Councillor Deehan that the golden hour was decisive in deciding where £712 million hospital was located. The idea that it's suddenly out of date is ridiculous. And it's very reminiscent to me of Animal Farm, where the slogans changed from 4 legs good, two legs bad, to 4 legs good, 2 legs better. So it seems those in authority can just change the rules as they go along. I have a few questions really for Garib, if possible. He referenced the attraction of surgeons through specialisms. If he could perhaps detail that slightly more. I also want to ask a question on emergency C-sections. I understand, I think Professor Lavery appeared here before us and assured us that because obstetricians conduct that operation, it's not going to be affected. And if there's any untoward occasions, there will be a middle level doctor on hand at least some hours of the day to cover. So I just would wonder if there could be a medical opinion on the accuracy of that. And I wanted to make a proposal. I don't know if it's correct to make a proposal at this stage, Chair.
Well, go ahead.
Yeah, I want to propose that we reiterate the decisions. I want this council to reiterate the decision and reaffirm our stance. The retention of emergency general surgery at SOAS, the fact that we've called for special hospital be put into special measures, the rejection of the June policy guidelines, the call for the resignation of the entire trust board of the Western Trust, and our readiness and willingness to pursue and consider, as appropriate, legal challenge on this issue. I want to finish by saying that tonight the people turned up in the darkness and the rain, and they listened to Reggie Ferguson and Brian Darcy of our community address them jointly on the steps of this council building. The people are united in demand of emergency general surgery at our local hospital. The people are looking to our council for leadership, and we need to deliver it. We have to save this service because this service is critical to our community, and every one of us should know that. So there should be no other way to go forward, but we have to follow through on this. Thank you, Chair.
Okay, thank you. So that's Councillor O'Coffey. At the end of this round of 3 speakers, I'm going to ask Alison to make a statement as well as Chief Executive. Councillor John Coyle.
Thank you, Chair, and thanks to the committee. I just have a question about the 83 or 84,000 that is going to be affected by the, the out of the hour to emergency acute A&E. As you know, what is the committee's views on when we have a large influx of international tourists and national tourists into the community? They are most welcome because we are a tourism destination, and it is vitally important that we have a service that they can avail of. Like myself, I farm at home. We hear of so many accidents that have prevailed, and not just in Fermanagh or Tyrone, but across the north where accidents happen. And we do know that we need to get there in a timely fashion so that, we get the best outcomes. Councillor Warrington stole me thunder on the golden hour, so I don't want to rehash that. But I am fully supportive of the campaign that you have run. It is positive. I was told last week that I should be more positive, so there it is. And I think that you are totally correct. Mismanagement of the trust has been, and I think that more members need to be from this area, and that they need to be more medically centred because they are the best people. If I have told, we have had experience from retired workers in the hospital, and I think that at these consultation events, they have been treated really extremely badly, and that I think that the review of general surgery, and when it was not consulted with by the council or by any of the general public, it should be thwarted and it should not be implemented. There is vested interest in it, and I would like your views on a way forward to get that abolished.
Okay, thank you, John. And now, Councillor Emmett McAleer.
Carlock, yeah, thank you. I'm going to say firstly, welcome. And whether you consider yourselves rebel rousers or not, I'm delighted to see you on here tonight. Secondly, thank you for bringing all this detail to us and indeed to the public who are listening in tonight. Your actions, commitment, efforts, insight and determination are to be fully commended. So thank you, Gora Mila Mayogif. I'd like to raise maybe something that hasn't been addressed, and that's the deep concern that I would have about accusations being made by the Trust. When they presented to us previously, they claimed that staff from the SOAS were accosted or castigated or attacked by members of the public. Further on to this, I'm aware of accusations being levied at members of the SOAS committee and an attempt to tarnish names and reputations. On top of this, at the recent sham consultations, there was at least one instance where the Trust recruited the PSNI to provide security, which is quite shocking, both in the picture it's attempting to paint and the completely unnecessary, needless public expenditure incurred, never mind the redirection of what we're already being told is an overstretched public service. And despite the PSNI publicly stating that there had been no complaints at any of the events to date prior to that being incurred. Now, the anti-mining campaign, which I'm very familiar with in my own DEA, knows all too well about the criminalisation of the local community and the focus made to demonise men, women and children who are from that local community and have taken a stance against objectionable plans which are being proposed and implemented in their own area. So I'd like to raise a question. Is this something that you fear for as this campaign progresses and is now facing? And if so, I'd like to ask the question, maybe what could the council do to support the local community which we're here to represent? And maybe following on from that, Chair, I'd like to raise a proposal for consideration that if the representatives in tonight thought it helpful, I'd be happy to propose that we request formally from Mr. Guckian what evidence he has had, not only of threats being levied at staff within the SWA, but claims that he has personally been alleged to have made against committee members and indeed against this campaign, which is solely aimed at protecting and preserving access to quality hospital and emergency surgical services provision. And this has been noted, I think, as through the presentations, including the one made early on by Jimmy and the establishment of facts by the University of Ulster. I'll rattle through. I'm not going to dwell too long because I appreciate we're time constrained here. I would concur with everything that was put forward, both in Jimmy's presentation and again by Aidan, in relation to the obvious negative impact that lengthening of any journey to receive emergency surgical surgery, which is by its very nature urgent and emergency case. I think it's worth noting in the presentation that the review of general emergency surgery, which was referenced, was not consulted upon because it wasn't a change in legislation. So that effectively means that the Trust are under no obligation to adhere to it, despite Mr. Guckian telling this council that there was no option as the review made it law. I would again express solidarity to our overworked and under-resourced health and ambulance workers who were out on strike. And just on a point that was raised in terms of the pressures facing Altona-Galvin at present, 5 hours ago they were sending out messages on social media that there were 96 people in the emergency department, 45 waiting admission following an extremely busy weekend. So that's on top of the added pressures that is being presented. Just thank you for that bit of levity, Chair. Thank you.
Right. So we've had 3 spoken contributions from members. Some were comments rather than questions. We had Donal, we had John, and we had Emmett. And just before I go to Reggie, Alison will remind us of procedures in respect of proposals and motions.
Chair, it's just specifically in relation to Councillor O'Coffey's proposal. All of the actions that have been identified have already been decided upon by the Council within the last 6 months. So therefore, we can't progress similar actions until 6 months has elapsed. We do, though, have a recent action from last week's committee that all outstanding matters that the Trust and Department have not yet responded to the Council, that we send a further letter. So some of the matters, particularly around special measures, are included within that also.
Okay. So I'm going to go to Reggie now to coordinate the response to the 3 councillors.
Yeah, well, just in relation to, I take it in reverse order, Councillor McAleer's query about the handling of the Trust consultation process. I was at the first public meeting in the Lakeland Forum. Now, it was a public consultation, so the public were there, the public were concerned. It was noisy. It was at times less than respectful towards the Trust Trust members that they might have wanted. At no time did it get out of hand. At no time did I see anybody in fear of any physical or abuse. A number of people spoke from the floor with the microphone, and to me, it was what a public consultation exercise should be all about. There were no policemen there, there were no security men, they weren't needed. Now, roll on to, I wasn't at the Tuesday night, roll on to Wednesday night in Irvinstown. The matter was totally different. There were a lot more members of the Trust staff there. You had to write down and give to these staff the questions that you might have. If you wanted to speak, you weren't allowed to hold the microphone. There was another paid member of staff there to hold it for you, as if you weren't able to hold it. There were security men there, paid for again through the public purse. and there were policemen round. And I believe in Belcoo, I thought it was very curious, and there may be something to your perception that they were trying to criminalise people who had perfectly valid points of view. Now, I believe in Belcoo that it was maybe more pronounced and that the police were there, the police who I'm sure could have been doing better things, limited resources. And I was disappointed when a question was put to the PSNI as to whether they had been engaged by the Western Trust. The first response was no, they just happened to drop in to see was order in place. Later on, they said, yes, the Trust had approached them. So I was disappointed in that. And to me, there was a definite upping of the security, and it was more, if you were at a meeting and wanted to speak, there was a lot more barriers put in place, and I think it wasn't as good a public consultation as there was the first night. So that was my understanding of it. And I think in relation to particular criticism of some of the SOAS group, maybe I'll ask Helen just to deal with that specifically.
I'm going to defer to my husband. Just once.
Thank you, Councillor McAleer. Just your question, I think, was around, do we actually fear for ourselves to a degree? I'd just like to also add that there was unfounded allegations made towards two members of our committee who had given a pre-presentation at the consultation event in Lisnaskea, an untrue allegation made to two locally elected representatives here in Enniskillen. The policy of whispering in dark corners seems to be one that the Trust have used in other situations that we've been made aware of as well. My opinion is that we shouldn't spend too much time focusing on this. Instead, we should focus on the positive message, okay? I think if the Trust are doing things like this, then we're getting under their skin, which is okay. That's fine. I don't have a problem with that. I just think it's a pity that they wouldn't spend more time focusing on the retention issue than focusing on the people who are trying to carry out a very strong and positive campaign.
Just on the question about C-sections, I'll maybe refer that again to Sam Grieve, if he is still here, still with us.
Yes. Thanks, Reggie. Can you remind me the C-section is, as I remember, the question was, can it be done with the presence of middle grade? Is that the question, Reggie?
Donald, what was your question about that?
Through the chair, it was just that we've been assured by Professor Lavery that in the context of an emergency C-section, it isn't affected because C-sections are conducted by obstetricians, and that they have spoken to someone, I think, who works locally from the Royal College of Obstetrics and Gynecology, who has said it's okay because there may be, at least some of the time, a middle grade doctor with some relevant experience on hand. And I'm just wondering if that's actually a safe procedure in your opinion as a medical professional. Thank you, Chair.
Thank you. Thanks very much. If a problem, usually the problems, and especially what I was talking about the gynecologists and obstetricians, it is not with the C-section. If any problems happens with the C-section, that an obstetrician will need a surgeon to help. So that's a very big problem. And it usually entails very excessive bleeding. And that would need the presence of a consultant, not a middle grade. And if the middle grade was called, they will definitely call the consultant surgeon straight away. But what I was talking about in general is the gynecology procedures. When they are doing laparoscopic, I mean using the cameras inside the tummy or operations inside the tummy, and they find sometimes some problems with the bowels, some other problems, and they would need the consultant surgeon to be present. So, and usually it's the consultant surgeon on call. He would be the one to help in that. The other question was about specialization. Now, when they discovered the Royal Colleges that there is a problem in finding the doctor, the consultant surgeons who would cover the emergency rota, they tried to create the emergency surgery consultant, or the trauma, they call it, consultant. That has failed because the amount of work and the severity of the work which their consultants were exposed to, they didn't continue. So the rotas for emergencies, it's actually goes back again to the consultants who are specialized, say, in upper gastrointestinal surgery or lower gastrointestinal surgery. Now, the specialization I was talking about, there was a problem with any cancer surgery because the Royal Colleges of Surgeons, as we saw in the previous presentation by John Brown, that they created that the outcome is better that if you gather it in a smaller number of hands, so you can get better outcome, which actually they didn't prove that true, you know, and still they continued down that line, and they forgot completely and continued down that line about like general surgery. Who is going to do the emergency rotas? All right. So what I was suggesting when I was presenting is that I was trying to create specialization in the SOA without touching the cancer surgery. I fought long and hard to keep the surgery in the hospital, and it's definitely, there is no general surgery going to continue without that specialty. What I was talking about is bariatric surgery, which is for morbid obesity, and it's very, you know, the SOA is well situated to be the center for this kind of surgery for the whole North. The SOA is kind of, I don't see any problem at all in attracting those consultants who are going to do that. We already have one. We already have one who I tried to help that he will start that specialty, but you know, he was faced by solid walls from the trust that he would start doing that. So develop those two specialties only. While there can be other specialties, you will have the consultants to cover the emergency road. Thanks.
Okay, Mr. Garib, and back to Reggie.
Just on John Coyle's point about the influx of tourists in the summer, I'm not sure what the figures are, but I'd be surprised if for a couple of months in July, August, June, that there wouldn't be 15 to 20,000 people coming to Fermanagh, so that they all need to be looked after if and when they need medical care, people out in boats and that type of thing. I'd be very surprised if that didn't increase the call on medical services.
Okay, so with that then, I'm going to go to the next round of 3 speakers. Each of you have 3 minutes maximum, and it's going to be Councillor Paul Blake, followed by Adam Gannon and Chris McCaffrey. Councillor Blake.
Thank you, Chair. Thanks for letting me in. Thanks to the group for the presentation there this evening. It was very informative. But for me, what it did was it corrected a lot of the wrongs and misinformation that had been spread from the Western Trust, and they used the platform of their, well, mismanaged consultation, because that's exactly what it was, when we looked at rooms and rooms of empty chairs. And if that's how they handle a consultation, well, it doesn't say much about how they handle the run of a hospital, because what they used that was an opportunity to spread their narrative and their own data, and what we've got from yourselves this evening clearly corrects that for the public. And I think that the public need to be aware of that you have, certainly in my eyes anyway, have clarified a lot of the positions. You've clarified the position about the golden hour, which is something that they used from the very beginning to dismiss the case that we had was around the golden hour. So that, I'm glad to see that that's been clarified. And also when you see that some of what you all had to put up with in your efforts, then it's highly commended, the efforts that you all went to collect the data that you have and the work that you've done over the past while in terms of the meetings prior to the consultations. I was at the one in the Bonacre Centre in Irvinstown, and if we just get people more aware what it is that you're doing and the work that you've done, so it should be commended. Because, what was I going to say on this point? What seems to have been going from the word go is that the Trust have taken any opportunity to kind of dismiss our rubbish people who are critical of them. In many ways, I felt like a naughty schoolboy there recently, because the Western Trust have went to efforts to go to my party leadership to say that I've been a naughty boy for challenging them. So I could like to tell Mr. Guckian clearly that I don't mind being a naughty boy and will continue to do so at any opportunity when I think that there is gross mismanagement. And that is exactly what the Trust is responsible for. Gross mismanagement of the Western Trust. And what has already been said, I think it was Councillor Green said about 20 years of mismanagement, he is exactly on point, because that's what it is. And why is it that we have to suffer? So one of the questions I'd ask is, how many trusts are being run by an accountant? Why are we suffering with an accountant? Is there something wrong there? But then also and before I forget, I'd second Councillor McAleer's proposal then about asking for clarity from Neil Guckian about as to what kind of threats were made against staff, because we are certainly condemning any efforts that were made against Trust staff. We support them, and that's why we do the fight that we're doing, is because we're out there for them. And then the second question would be for Dr. Grebe, would be around specialty and the rota, whereby doctors would work, or surgeons would work in, say, a hospital like SOAS, 1 to 6 rota, while in a bigger hospital like the Royal Victoria, possibly Anthony Gelvin, you're operating on a 1 to 22 rota. Does that then affect your ability to perform emergency general surgery, which for them is specialised surgeons? So around that question, so that's it.
Thanks very much. So that's 1 of 3 speakers in this round. Councillor Gannon.
Thank you, Chair. And firstly, I'd like to thank SOAS for their presentations tonight and commend you all on your work so far. It has been a pleasure to support you in the campaign. I look forward to continuing this fight with you. And I'll tell you what, Chair, what was presented to us tonight was a damn sight more professional than anything the Trust has presented to us in relation to this crisis. There was more evidence and data tonight than what the Trust has used to back their decision, which is totally staggering. So maybe the Trust should learn how they should conduct their business from SOAS. You know, the review of general surgery, as was stated tonight, there was no consultation, no equality impact assessment, no rural needs impact assessment, and no reference to accessibility was included in the clinical standards for emergency surgery. This, to me, makes that document an illegitimate basis to make any decision on any service. Therefore, in my opinion, this makes the Trust's decision on emergency general surgery and any decision they take me using this document totally illegitimate. This is not a recruitment issue. It's been said it is a retention issue, and the Trust need to stop parroting the line that it's a recruitment issue, it's retention. And all the evidence that's presented here, any reasonable person would look to these this evidence and say it points to management failure, and it would automatically raise the question, is this malicious management failure or is it one due to incompetence? And I don't know which one would be worse personally. The Trust, clearly, from looking at their consultation document, is bereft of ideas on how to maintain services, and that's if we actually believe they want to see of our services and maintain them. But we know the Trust is most definitely listening tonight. They'll have someone listening in, so there was a clear message from SOAS to them tonight. In their consultation, they ask for alternative solutions, and again, we've heard it tonight. The SWA needs new management. Thank you, Mr. Patton, for raising that. And the Department of Health also have a role to play here. But ultimately, without an executive, the civil servants won't make the decisions that are needed. There does need to be a political will to make the solutions that have been outlined tonight happen. SOAS have a positive vision for this hospital and for the area and health services here. And I believe us as councillors, every single one of us shares that positive vision for our area.
Just concluding point now, Adam, thank you.
My question is maybe more for the Trust. Will they do, and will you as the Trust, if they are listening, do the right thing and immediately reinstate all services? Or will you hand over management of SWA and the southern area of the Trust to those who have the will, the heart, and the ideas to effectively deliver services for people in Fermanagh and Tyrone? But I'll leave it there, Chair. Thank you.
Okay, thank you. And then moving now to Corleor Christopher McCaffrey.
Gurmalgat, Kyherley, and I'll keep my comments brief as I know we've had a long sitting here tonight, but just well done again to everyone from SOAS and all the work that they've done on this campaign. I think you can see from tonight all the councillors in this chamber are totally united in solidarity with yourselves as representatives for this cause. It's absolutely disgraceful that we're in this situation to begin with, and as rural dwellers or as people in a rural district, that we are facing an inequality in health. And of all the inequalities, inequality in health is the most shocking and inhumane. It's absolutely appalling that people in our own district, the population of Fermanagh and part of Tyrone, will not be within inside the hour travel time to emergency services. It's incredible. And I think we do have a board that's been ran by a group of people who unfortunately know the cost of everything but the value of nothing. And I can only compare the measures they've taken so far to try and solve the problems. And again, I don't know if it's incompetence or being malicious, as Councillor Gannon has stated, but I can only compare what they've done so far as trying to cover the stab wounds of Julius Caesar with sticking plasters. It's just, words don't even do it justice how terrible this is. I really just want to express, as a person who represents a rural district of Erin West, and someone who has family who've been through obviously the medical system and people who work in that same system, how really disappointed I am in the leadership we've seen from the Trust so far. I think if I was to select a new board, I know some of the people who I'd be asking to step in, but really just this, more of a comment just to say that we're obviously in full support of what yourselves are doing, and I hope that tonight you've seen the will and the fortitude coming from this chamber to fight on this issue, that the lives of the people in our district are not worth any less than anyone else, and we'll be fighting for full and permanent reinstation of the services in our acute hospital in Fermanagh. So
okay,
thank you all.
Bruce. Okay, so Reggie, Councillor Blake, Councillor Gannon and Councillor McCaffrey made various points and asked questions. Do you want to come in, Helen, at some point? Through you, Reggie.
Councillor Blake mentioned, the councillors made statements as well as asked questions, but Councillor Blake compared the rota of SWA to the Royal Victoria, and 1 in 22 in the Royal Victoria and 1 in 6 in SWA. And as a comment, I mean, there is no doubt that the way medical training and medical services are set up in Northern Ireland, it is, and you would expect that a city would have more assets, more focus. But I think particularly Northern Ireland is very Belfast-centric. And there is no doubt that there are 4 acute hospitals within about 3 miles of each other. So it's not a fair representation. It's historic. There's no doubt that a hospital like the Royal Victoria is a regional hospital in that it must have services nowhere else has. Neurosurgery, serious heart surgery, all those other specialities you need to rush your patients there. So there's no issue with having one particular hospital, but 4 acute hospitals within 3 miles of each other, then Antrim Area Hospital. It's not fair, it's not equitable. And that is a theme which has been coming up all night, that we are getting the wrong end of the stick all the time. And I think in this particular campaign, we have to hammer that point that we deserve an acute hospital. The people of this area deserve an acute hospital, and we won't settle for any less. Helen, I'll just hand this over to you for 1 second.
Thanks, Reggie.
Reggie, can I?
Paul and Adam and Chris, I'm going to kind of roll the points into one if I can. I think the fact that SOAS is on the table tonight, I think we have been thanked profusely by you, but I think what I want to do is to thank the people that we're representing for coming forward to us. We're being watched right now by several of the people who have lost their jobs and had to leave their jobs at the hands of the trust. We're being watched by parents who have had to drive their children while they were very ill up the road to Altnagelvin. And we've spoken to staff inside the hospital. And I think that the only consultation that is really worth discussing is the consultation that we have now garnered as a group with the staff. And some of the comments, just to read a few of them to you. The Western Trust cannot be trusted. They play one side against the other. They do this repeatedly, even with their own staff. Staff are bullied into a state of despair. Staff know that the proper distribution of surgeons in the Western Trust and over-trust throughout Northern Ireland is not a real problem. It should simply be a condition of employment. Many surgeons go into private practice to ensure they have a range of experiences. They see a chronic lack of theatre spaces in Northern Ireland. SOAS is totally underused. They say the Trust does little or nothing to inform, listen, or to consult SOAS staff who are superb carers and professionals. It is not clear to staff whether the Trust mismanagement is dysfunctional or deliberate. The Trust values paper resources more than they do patients, which staff are left to deal with. Senior staff are disillusioned and are living to protect their reputations and their future. Staff know that acute trauma life support principles are not applied here. And that acronym again is ATLS. It is recognition of appropriate time for acute care. And Brendan, that's the so-called golden hour, my friend. These are the words which have been gathered from in the corner. And the staff are, there's Mary Kelly looking for tea. They are a superb asset, this staff. And as I said, to be able to sit up here and represent how they feel is an overwhelming thing. And I did note tonight that as all of those people stood outside the council in the rain, there was no need for any security. There was no need for any crowd control. There was just a willingness and a desperation, and there is so in this community. And I know, Rosemary, you and I have sat and talked health inequalities for too many years and too many campaigns. But my idea of identifying a need is to infill that need, not to further deplete. And I think what's happening in Southwest Acute is absolutely scandalous in terms of addressing already known inequalities. And just, can I ask, because several of you have done it, it's probably totally inappropriate, but I am the political, unpolitical one.
I think you're
Can
very
I
political,
ask
but
the
you're not
councillor?
you're not party political, but you're
I'm
political.
certainly not being politically correct, Barry. But I would honestly urge the council, I don't care what parties you belong to, your people, every one of you has heard by now, other than the narrative of the trust, you've heard of case studies. The picture is not all happy and it's not working. And I would implore you to represent the people that we've heard from and that we are bringing forward and being warned by the trust not to do so, because the trust are making it very, very difficult for people to remain anonymous. So I would urge you to commit to the very strong positions that you took, because you are listening every day, the same as we are, to stories which are heading up the road to Alton. We have heard of outcomes which are, I'll just say, very bad outcomes. And I'm quite sure that there's not any one person in this room who could look me in the face and say they haven't heard that also.
Okay, thank you. Now, we have 5 remaining speakers. Everybody knows there's a degree of time constraint. So I think if each of the 5 speakers took around 2 minutes, you know, if that's in order, but you're entitled to your full 3 minutes, Diana. You're entitled to it. I'm just asking for general cooperation, not for anybody to be repetitive and to ask salient points. So we have 5 remaining speakers. It's 20 to 10, and we have items to deal with beyond 10 o'clock, which will take us right through from 10 to 10:30 once we get this extension of the meeting. Councillor Armstrong.
Thank you, Chair. I'll not repeat a lot of the thanks, but it's a commendable effort and I fully support the measured and the researched information that you have produced here. Congratulations to everybody involved in that. I wanted to go to Professor John Brown. Very interesting report that he was involved in, the Nuffield paper in October, and it said it was concerning reconfiguration of emergency surgery. No further capacity should be removed from overstretched systems in the vain hope of producing efficiencies and safety improvements that never actually arrive. Smaller acute hospitals represent an opportunity for growth. The structures already exist, and with the investment could alleviate the pressure on larger urban sites. This approach would also be consistent with other policies such as levelling up investment across geographical areas, environmental policies and policies to reduce income inequality. It also mentions population ageing, the workforce crisis, the aftermath of the COVID pandemic, warrant a focus on stability rather than ambitious system reforms with little evidence. Thank you, Professor Brown, because I think the Trust needs to look at that. That actually encapsulates what we are about, what we need here. I think the Management Board of the Trust, its duty of care is also to its staff. It displays a dereliction of duty, exposing middle-rank doctors to a situation of intervention with potential litigious repercussions. As Dr. Garib said, they need senior trusted surgeons. It's just, those are the points that I just want to make. Also, if I could just ask one question, what is the experience of the Highlands and Islands in Scotland? That is a remote area where I do believe the acute hospital system has not been working, the removal of those emergency surgery. So a quick comment on that, please. Thank you, Chair.
Thanks for being brief, Diana. I'm going to go now to Councillor Barton.
Thank you very much, and I will also try and be brief. Just to say thank you very much to the team here tonight for your work and the research and the results that you've produced. It's been very, very interesting. Thank you. Just 2 points. One is in relation to the advertisement. I was speaking to a former consultant from the hospital, and he did suggest that there may be problems in relation to the journals, the medical journals where some of the positions are being advertised. I'm just wondering, could Dr. Garib or someone else comment on that, on where these advertisements were? And my second question is addressed to you, Robert, and that is, you spoke about a new model. I'm wondering if you could put a little more flesh on the bones.
Okay.
Thank you.
Thank you very much. And Councillor Elliott.
Yes, thanks very much, Chair, and thanks to the panel again for the information. Obviously,
the study there with regard to the travel time, in my opinion, was quite shocking. You know, I know there's been a lot said about the golden hour, and Councillor Coyle's correct when he talked about the farming community. After doing 19 years myself there with the Fire and Rescue Service, sometimes it takes 40, 45 minutes to get somebody released, to get somebody removed from a vehicle, you know, or whatever the accident happens to be. And I know in this day and age now, and the great work that the air ambulance does, and I think there's a lot of reliance maybe on the air ambulance when you look at what's going on here, and they do a fantastic job, but weather dependent, and you know they can't come at all times. And then we hear about the Northern Ireland Ambulance Service; it's already stretched. So, you know, where do we go from there? With regards to the solution, a gentleman said, you know, creating the surgical specialities. So if we can do that in the SOA, we saying that emergency general surgery then can come back to the SOA with the experts that's there. Well, that's good. And then again, with regards to the panel, Mr. Patton and the panel, be commended for your vision. Thank you.
Okay, thanks very much, Keith. And two further speakers, Reggie. Usually question time on the TV. You're under pressure here. Okay, Anthony Feely, Councillor Feely, followed by Councillor Coyle. That will conclude the speakers from the floor. Okay.
Thanks, Chair. And Reg will be glad to know I've no question. I'll just make a comment. I was going to talk at all. I was going to ask a question there, but Donald has already asked it, and it's the thing I'd be very worried about was the emergency C-section. I've seen my own child was born that way, so I know it's very important. It's just a matter of life and death, so I'd always be very worried about that. I just wanted to come in to commend the group on the work they're doing and all the information they give us there tonight. There's some information there, some very scary stuff, especially about Clare and the hospital in North East, temporary closing and all the pressure put on Limerick, and that is what would happen here. And we're right to fight on and not let it happen. So I just want to make a comment on that, and it should give me solidarity to you. But one thing that does annoy me, and I did bring this up to when we met the group themselves, when they mentioned Sligo, and I think it was Daisy mentioned Sligo there earlier on there, and I live down in Garrison, just on the Leitrim border there, and the people I represent, we'd be 35 minutes from Enniskillen, so we'd be over 2 hours to Derry, and we are close to Sligo. But at the minute, Sligo is a complete joke altogether. I had to listen to a local radio station in there, Ocean FM, in the morning, and there could be 70 or 80 people on a trolley every morning. They're in the top three, I think, after Letterkenny, after Limerick, Cork maybe, and Sligo was in top 5 anyway, and Letterkenny as well. If I was chatting to somebody from Letterkenny that was on a trolley for 2 days, waiting for 2 days. But Sligo was just a no-no, and I have been chatting my colleagues in Sligo and Donegal about this. So wherever they got Sligo from, and even getting an ambulance from Enniskillen back down to Sligo, you drive from Garrison up to Enniskillen and back to Sligo, it was just making no sense. But they didn't give me a straight answer that day when I asked them about it. So that just really annoyed me when they mentioned Sligo. And this, as for even going up to the southwest end of Derry, and I'm not going to go into any case, but I know it's not working. I know a guy from Garrison has went through that. Lucky he's came through, but it could have ended up the other way. He could have died after, but he's still not recovered. So I just want to make them few comments, but no question. But and well done to the work. And fair play to the guy that spoke at last, that Mr. Patton, that gentleman, showed a bit to be positive there, and I think that is the way to go. As Seamus said there, if you're managing a football team, you wouldn't last too long. If you're in the Premiership, you might get 20 days, let alone 20 years. And in the GA county manager who's on the right pressure, you'll not get the time. So I think it's time to change. But well done to.
I think you packed a lot into your 2 minutes there, Anthony.
I'm rushing, Barry. I know I want to get to the ammonia.
You did well. And finally, and Reggie, it's your challenge to deal with 5 questions after Councillor Coyle concludes. Councillor Coyle. Sorry.
That's it. Okay, thank you. And thanks to the group for the presentation. It's important that we as a council are supporting yourselves and the community and the growing concern regarding the services in our hospital. Other councillors have raised some of the issues I had, so I'm not going to repeat any of them. Your presentation was very informative, and I'm not sure if you said at the beginning that we would be able to get a copy, but I'd like to request that we could.
And also suggest maybe that you send the Chief Executive a copy and some of his management, because they do, like others have said, seem to be a little bit more factual than the stuff that they're telling us. In recent report, but I'm not really asking the question either, I'm just going to, from a staff point of view, in a recent report, NHS staff are 3 times more likely now to quit their NHS job due to issues of work-life balance than 10 years ago. Stress and mental health are all part of this. And this leaves staff that are left working there. We're understaffed, underpaid, increasing pressure and worry about their jobs and their future just added to that. There's an issue around safe staffing, poor pay for a hard day's work or night's work is a major issue. The Trust and the Department of Health need to face this issue and sort it out as quickly. We need the Assembly back up and running so that the Department of Health can start sorting these issues out. So many of them clap every Thursday. But we're now out on strike this morning, and we'll go out on other days and we'll keep doing it because this is the thanks that people got for working through the likes of COVID. The staff actually go on strike.
Point, if you wish. You can make a concluding point now, please.
That is it.
Okay, thanks very much. Okay, thank you. So, Reggie, over to you.
I just quickly cover a couple of things, and then I'll go to Robert and then to Jimmy about specific things. Debbie, yeah, your points are well made. I think while one is tempted to blame the Western Trust for everything, it's not fully their fault. I think the Department of Health, I mean, for example, nurses are paid less in Northern Ireland than anywhere else. Why? I don't know. Government has let it be that way. I think it's shocking. Secondly, that if you say they clap them every Thursday and then they make them go out and strike to give them, they haven't offered a decent pay rise. The whole country wants them to do that. Why they're making that point, that's a thing could be changed very quickly. Councillor Elliott, you talk about the air ambulance, doesn't go at night apparently. It was one of the silver bullets that Neil Guckian said. The Trust apparently are paying 10,000 a week to a private ambulance service up in Limavady. That's $500,000 a year. How many consultants could you get for that? Are not clear whether all the staff and the ambulance are medically trained. Not sure about that. And it is weather dependent. And then the last 2 points, I'll go back to Robert, who specifically was asked by Councillor Barton to flesh out the model that he had put forward. I didn't think he'd made a bad job, but maybe he'll have another go at it. And then I'll go to Jimmy to deal with the question from Diana about the Highland and Islands and the rural medical practices. Thanks.
Thank you, Reggie. Thank you, Councillor Armstrong, for your question with regard to Scotland and the rural Highlands and any similarities that there might be. Our research group has done an awful lot more research than we have presented here tonight, and we obviously can't go through all of the information. There is a significant amount of study that shows that even in rural areas like Scotland, like the Highlands, that efficient solutions can be put in place. What I would draw your attention to, though, on the only research article that we did refer to, okay, when we talked about the 1% increase for each 10 kilometres, okay, on a straight line, that article, and it's important that the council understands this, that article looked at, it's what's called a cohort study. It looked at 10,315 cases across 4 years, across 4 ambulance companies or trusts or whatever in England and Wales. And they looked at both urban and rural, okay? For those 10,315 cases, the maximum rural straight line distance that anyone had to travel was 58 kilometres. Now, if you take a look at the figures that we put on the graph, and I do understand that you haven't had a chance yet, there is not a single place within Fermanagh that was under that distance of 58 kilometres straight line, not a single place. So we've got a very well-respected study, okay, that's in the top 5% of cited studies on the BMJ, okay? And for 10,300 examples, there was no case was more than 58 kilometres. For the people that we're talking about in Fermanagh, there's nobody that's under that. We've got up to 84 kilometres in straight line distance for people living in Belcoo and Garrison that they have to travel, okay? So what the figures that we're talking about here, they're outside the pale. They're not normal. Nobody is asked to do this, okay? And it's something that council needs to be strongly aware of, that when we come up with what is an ambitious solution, okay, it's because this is an extraordinary situation that we've been put into. The only other point I'll make is to Councillor Coyle, and thank you for your comments. Yes, we are going to make copies of the PowerPoints available. I have copies here actually of the two reports that we talked about, the one from Ulster University and the one from us, there's one for the chairman and one for the chief executive, just to be part of the formal council record as well.
I just very quickly want to mention Councillor Barton, if that's okay. Rosemary mentioned about recruitment, and that's something that I've been reading for quite a while, before October, to be honest. Lots of examples of not wishing to advertise for appropriate consultants, it would seem. Job adverts with plenty of them called doctors with an interest in, which is a lot cheaper and a lot less specialised than a consultant. Speciality doctors with an interest in, clinical fellows, most of them for medics. And since the report for surgical, the review of Northern Ireland itself was published, the Trust have methodically run the same advert for consultant surgeons, and they are the only adverts for consultant surgeons, and they've run them based in Altnagelvin and working trust-wide, which completely negates any link with the review of general surgery. As of the 13th of February, despite the fact that we have all been told, and we read it in the media last week, that our Obsgyne team are in collapse, until the 13th, there were no consultants in Obsgyne advertised for. And I have checked both the HSC jobs, and we do that on a fairly recent or regular basis, and also Direct Medics website, where there are temporary jobs for Obsgyne middle grades. So I do think that the recruitment is as disingenuous as the retention. Keith, the only one I wanted to bring, the Air Ambulance, as you know, is a charity, a brilliant charity, but it won't fit in anywhere that is wilder than outside the SOAS and a good football pitch or rugby pitch, and it's daytime and working hours only. So we're really out in the sticks here. And then Robert, if you...
If we have time, Mr. Chairman, I'll make a few comments in reply to Councillor Barton. It's early days yet, it's very early days. We need to understand how the Trust gets separated out and into what kind of status it has. But there are a number of key things that are required to make a success of it. It has to have a board which is representative of the people that it serves. And on that board, in my opinion, and this is a personal opinion, there should be a cohort of doctors. Doctors know how to treat patients. You can't have people that sit in an office somewhere in Derry or wherever it is, making board level decisions about a hospital in Fermanagh. It just doesn't make sense. Second thing, a CEO, a chief executive, has got to be a chief executive of this hospital, not of 3 or 4 hospitals. I wonder, for example, how often Mr. Guckian has walked the corridors of the SOAS and spoken to the staff and say, how are you getting on? what do you need, how can we help you, etc., etc. A chief executive is on the job every day. And so the chief executive will be his or her responsibility will be to this hospital only. That's a big difference. And the other thing it will have is specialties, and Dr. Garib kind of talked about some of them. The specialties will be designed, or if you like, will be laid out by somebody like Mr. Garib, who is able to say, look, these are the things that you should have. He's already mentioned bariatric, and there'll be others. And they'll be, and the aim should be to make a really good job of these and have good surgeons and good people involved, so that this hospital becomes the go-to place if you want to get this kind of work done. And that way it complements the whole of Northern Ireland health system rather than trying to compete. So I think there's kind of guidelines there that I think are emerging. But, you know, we all need to kind of make a step forward and be committed and move it along to get to the point where, yes, now we have a new institution here.
Okay, thanks very much. Okay. If invite Reggie now to make a final spoken contribution.
Just to say, I'm not going to say very much longer because it's after 10 o'clock. Just to thank you once again for listening to us tonight, and thanking everybody who's contributed, particularly Dr. Brown and Dr. Grieve, who've gone to great trouble to be involved in this tonight and to give us their words of wisdom. And hopefully we will make some progress in this matter. We're determined to win this fight. You're all members of political parties, so get in the ear of your leaders and let us try and move forward in a positive way and to serve the people of this community. Thank you very much.
Okay, and can I just say, just on Councillor Armstrong's point about Scotland, just to, I recall, it might be a bit dated now, but Dr. John Robb, I think, has done a body of work on the Scottish situation. Is that right, Jim?
We have done a significant amount of work with regard to looking at hundreds and hundreds of research papers, and there just isn't enough time. This was a detailed enough forum as it was. We actually did have a conversation that we think that there may well be an opportunity for some of SOAS to present to the Health and Social Care Subcommittee in terms of trying to get into details that we haven't been able to get into today, and in terms of trying to be able to push things a little forward as well. That we can certainly cover some of that information then.
Okay, what I'm going to do now, members, is I'm going to take a proposer and a seconder to extend the meeting for half an hour. I've got Councillor John Coyle and Councillor Blake assisting me with that. Others were willing, but you've got to be sharp. You've got to be like a sprinter. So what we're going to do is we're going to extend the meeting for half an hour, but we're also going to take a 5-minute recess now, and that's what we'll do now for the next 5 minutes. So proposed and seconded. Okay. Again, this time proposed by Councillor Gannon and seconded by Councillor Feely. 2. We've dealt with the major substantive submission, presentation from Our Acute Services, and we're about to move into item 4. But before we do, I want to revisit Councillor McAleer's proposal, and I'll bring Councillor McAleer in now. Emmett.
Cormac, Carlock, yeah, thank you, Chair. Just to, I'll reread the proposal that was made and thankfully seconded by Councillor Blake. So having spoken to the representatives, they are agreeable and do think it would be helpful. So I'm proposing that we request formally from Mr. Guckian what evidence he has, not only of the threats made to staff working at the Southwest Acute Hospital, but also the claims that he personally has been alleged to have made to SOAS committee members, and indeed against this campaign, which is solely aimed at protecting and preserving access to quality hospital and emergency surgical services provision, and was noted in the presentation made by Jimmy Hamill, the facts established by the University of Ulster. So that's my proposal, Chair. Thank you.
And that has been formally seconded. And is that agreed, members? Agreed? Okay, I don't anticipate any dissent on that. So I haven't got any dissent on that. Okay, so that's agreed. And I think we're ready to move on. Okay, we're going into item 4 now to present further draft response to draft ammonia strategy. And I think our director, Kim McLaughlin, is going to lead on this. Over to you, Kim.
Thank you, Chair, members. So this paper was first presented to RNC just last week, and there were some comments and feedback given at the meeting in relation to the draft response which was presented. The consultation period runs until 3rd of March, so a submission needs to be agreed in advance of then to submit to DAERA. The draft consultation response is attached as Appendix 1 to this report. It picks up on some of the comments made at RNC and also further comments which were submitted by members following the RNC meeting. And the attached to paper A, we have the consultation response as Appendix 1, and the DAERA document is also attached as Appendix 2. So the response does recognise the need for action to address ammonia issues and the impacts on the environment and on human and animal health, but it also expresses concern at the potential impacts of the measures on the agriculture industry locally and on our rural communities in Fermanagh and Omagh, and calls on DAERA to review its approach alongside a number of the associated statutory assessments. Some general comments have also been included at the introduction to paper A. So it's presented for members' endorsement and for submission as the Council's response to the draft ammonia strategy, Chair.
Thank you. Councillor Green.
Thank you, Chair. After reading over it, there's some things I don't necessarily agree with. Most things I do. So at this stage and at this time, seeing we had a long debate on it the other night, and all councillors had an opportunity to send in amendments or ideas. So I am proposing that we go with this draft tonight.
Okay, thank you, Cormac. And then Councillor O'Coffey.
Yeah, thanks, Chair. And I certainly was very critical of the report in which we're, the strategy or the draft strategy in which we're submitting a consultation on the night. I don't think it tackles the issue substantively, frankly, at all. The Northern Ireland produces 12% of the ammonia emissions of the UK, with only 4% of the population of the UK. Now, there's a degree of reflection of the economic base and the size of various agri-industry companies here, and the predominance of them, and that's perhaps unavoidable to an extent. But I don't think that the draft strategy addresses that at all. And I made my points quite clear on the night, I thought. But unfortunately, the response that we have before us appear to actually dilute down the protections, which I thought most were agreed with, which were around things like special areas of conservation. 98% of special areas of conservation and 83.3% of special protection areas have nitrogen disposition rates exceeding the critical load. These are Northern Ireland's most important habitats. As originally set out in our submission, there is nothing really around ASSIs, areas of special scientific interest, which we have a lot of, thankfully, in our council area. And 95% or 95.7% of ASSIs have which are nationally important sites had nitrogen deposition rates exceeding critical load for at least one feature. 100% of SACs, 100% of SPAs, and 99.7% of ASSIs in Northern Ireland have ammonia concentrations greater than 1 microgram per cubic meter, which means that it's affecting lichen growths, mosses, and ecosystems upon which they are dependent. And 27.8% of SACs, 21.4% of SPAs, and 24.6% of ASSIs in Northern Ireland have ammonia concentrations greater than 3 micrograms per meter, which means it's actually affecting heathland, semi-natural grassland, and forest ground flora. Now, I thought the proposals, no one was really opposed to any, obstructions to, depositing slurry and the like on these ASSIs, SACs, and so on. I take that there may be issues around the distance from them, but I think the removal of the sections that we had in the original report is something that I could not support, and as such, I would like to make a counter proposal that we actually go with the original submission, because as bad as as many criticisms as I may have had of that, I would be more concerned, frankly, with an approach by this council on this very important issue for our environment and our ecosystems, that we would be actually setting the bar even lower on the most important special scientific areas in our council area. Thank you, Chair.
Okay, thank you very much. Alternate a bit with WebEx. Councillor Swift.
I was content and satisfied to second Seamus's proposal, and for all of the reasons outlined. We have discussed this and indeed discussed extensively at our agriculture liaison group, where this particular topic has probably been high on the agenda for indeed the guts of probably the last 4 years, indeed, the new term. And I was satisfied that the long-term target, indeed to 2050, is to reduce ammonia emissions to a point where the critical loads of nitrogen deposition and the critical levels of ammonia are at a more sustainable and pragmatic place. Having said that now, Donal Coffey has come in with quite a lot of things there that I suppose leaves us, head scratching. It's a pity, Donal, that you didn't provide us with that information in advance, but because I think we all agree and would categorically agree that it is vital that any measures proposed in our draft ammonia strategy do not contribute to the loss, particularly as we have talked in our liaison group, of family farms, which have been part of our landscape for generations and which would have a devastating effect on our rural communities, all of which we have carefully considered. I would state, in my humble opinion. So, Cathaoirleach, I would go back maybe through the chair to ask him, just to be sure on the points that Donal has raised, that we are and can be satisfied. But as I said, I was content and satisfied to second Seamus's proposal. We have discussed this at length, but obviously I wouldn't want to negate any responsibility. We have worked tirelessly on this particular topic for all our farmers in our super council area. Guramagat, Cathaoirleach.
Yeah, Guramagat. Just, I need to clarify, Bernice, are you still content to second Seamus's, or have you been knocked off course, maybe?
Well, yes, I was still, but you know, if there are other councillors who would like a little bit of debate, I'm aware of the time, and you have AOB, okay. You know, just a wee quick one, yeah.
No problem. Thanks a million. Mr. McAleer.
You want me to
Sorry, Kim, did you want to come in at this point?
Kim,
Thank you, Kim. Yep.
Just to comment on Councillor Swift's query, I suppose the response does not oppose any of the targets or the pillars that are set out in the strategy. We've noted the targets and also confirmed that, you know, we have our own net zero targets and our own biodiversity plan, and the response does set out the objectives within our own biodiversity plan. We have asked really that DAERA widen the scope of the pillars in the strategy to include a pillar which supports sustainable agricultural production alongside the pillars that are there. So it's really about broadening the scope of the strategy to recognise the need for sustainable, to support a sustainable agricultural sector.
Okay, I need to go to Councillor McAleer now.
Yes, thank you. I would share the sentiments of Councillor Coffey. I actually think the resubmitted or the represented document before us tonight actually waters down a lot of what we had set to work on the first night. It goes from welcoming the introduction of the interim targets to noting them, which is obviously a retrograde step. It does note throughout the document that we are prioritising funding and full financial compensation for the agricultural sector to enable the strategy, and that there is a focus on, as noted as early as the first paragraph of the first answer that we give, particularly those very small family farm business which are predominant in FODC. I do think it is very telling that reference to particularly designated sites such as the area of special scientific interest, nature reserves, national nature reserves, or marine nature reserves. That seems to have been completely missed in terms of any focus from the ammonia strategy. And unfortunately, that seems to be something that's been culled or removed from the response before us tonight. And again, looking through, I suppose, some of the obvious omissions or crucial omissions, when you're looking at our biodiversity targets, when you're looking at transboundary analysis, legal obligations that I referenced the last night, particularly in collaboration with the Water Framework Directive, I don't think this is a step forward. I think this is a step backwards. So with all that in mind, and again, looking at combination assessment, looking at air quality assessment, health assessment, and indeed project splitting, I think the original response is much stronger, and I would be inclined to support that and second Councillor O'Coffey's proposal. Thank you,
Okay,
Chair.
thank you. Thank you. Moving on now to Councillor Rennie.
Well, thank you, Chairman. And I suppose at the outset, I really want to say thank you to Kim for bringing the draft ammonia strategy consultation response to us here this evening. I'm sure it took quite a bit of time to go through all the responses. It is a fairly hefty, it is a very huge subject. And I would want to second Councillor Green's proposal. I think perhaps at this stage it is the best that we can achieve for everyone. Of course, time will tell as to the detail as we travel along the road of the emissions reductions. I think that we have come quite a long way in recent times, Chairman, and we do see the value of a good number of the items that have been the questions that have been answered here in the strategy thus far. And I'm pretty sure that we will live to see what has been the best that can be offered to us at this time. So
Okay.
I want to once again say thank you to Councillor Green for his proposal, and I'm certainly very willing to second it.
Okay, thank you very much. And just mindful of time and a very urgent matter or two to be raised as well. Councillor Barton, Councillor Feely and Councillor Stevenson. So Councillor Barton.
Yeah, I'll be short. Just to say thank you again, Kim, for this consultation response. Yes, there are some issues within this response still that I'm not totally happy with, but that doesn't say that I wouldn't be supporting it tonight. Also, I think you have within that response recognised that farmers do realise there is a need for an ammonia strategy. And I think that's a huge step in getting them to recognise that. So all I would do is to commend this for support.
Councillor Feely.
Yeah, thanks, Chair, and I'll be brief again for I know we're under pressure. But I was going to come into second Seamus' proposal there, but I'm glad now Bernice and other council has supported it, and it's going to cross.
I think it's been formally seconded by Councillor Rennie, I think.
That's fine, that's fine,
Yep.
but I just want to make a wee comment to Barry about it as well. And I commend Seamus on the work he done on this. I missed this meeting, I think it was last week. In fact, it could have been that meet Valentine's Day. I was off that night, so I wasn't at it. But I don't miss many meetings. But I commend Seamus for the work he done that night. And I was chatting to Seamus about it since. So it's
You're supporting Councillor Green's.
Oh, definitely. Well, I would be one of them small farmers that we're talking about, you know. And I know there are issues with the environment, and we have to that. We have to kind of think of both sides. That the small farmers, well, has to continue on farming, and I have a story myself. I know it's a problem getting it out, but I will do these new rules and try and get it done with the pipes and that from now on. But it's going to take time, and I'm glad that we have put in there provision for finance and getting extra help to buy this machinery and stuff like that there. So I know there's a few things wrong, but I would be happy to support it. And you know, we can't be penalising the hill farmer all the time, and some of the other bigger farmers will be getting away with it, you know, but we have to keep a level playing field for us all, you know, so that's why I'll be supporting this, and well done to Seamus for doing a few changes.
And finally, Councillor Stevenson.
Thank you, Chair. Yeah, just happy to support the document as it has been represented to us. I did make the point at the last meeting about small farms and single and family farms, and you know, with my job as a contractor, like I know what it's like out there, and we're not going to get it right. It's not perfect, but I mean, like at the end of the day, I sit with as I say, an inspection every 18 months on my own farm to do with all this here anyway. So we know it's coming in, and we know what we have to do, and I think it's just a matter now of educating and getting the way around it.
Okay,
Right,
thank you.
Chair.
So the first of the two proposals to be formally seconded was Councillor O'Coffey's in this instance. Isn't that right? Nobody's disputing that. I don't think Bernice seconded it. Councillor Green, had Bernice seconded it, she would have got in. But we're paying very close attention up here, you know. But anyway, so we're going to...
That's a technicality, Barry. That's a technicality.
No,
but I'll forgive you.
Okay, so but what we'll do now is, Alison, can you help me with the procedure here? Okay, are we going to set up a vote, or are we? A recorded vote has been requested, which means that we set up a vote, isn't that right? Okay. Yes. So the vote is being set up presently. And this is Councillor O'Coffey's proposal to adopt the original policy paper, draft policy paper, seconded by Councillor McAleer. Give me the nod, Donald, whenever you're ready. Apparently, I'm unable to take comments during a vote. That's what I'm being advised. Okay. Okay, before we conduct the vote, and the vote is underway presently.
No vote online, Chairman.
Okay, no vote has been. Okay, that has not yet come up, but it will. Okay. So the WebEx vote is up now. Okay. And that'll stay for a minute or so, will it, Donal? Okay. Is that, isn't it? Right. Okay, I'm going to get the result read out now of the vote.
Thank you, Chair. We had 3 votes for and 22 votes against, so the proposal falls.
Okay. And then, members, if I could, we can go to Councillor Green's motion now, which was seconded by Councillor Rennie.
And me.
Okay. Which means that we'll be setting up a vote again, both on WebEx and in the chamber. Letter correspondence. Cut side. When we put it into the committee meeting for knowledge.
It's just it's tiny, but it's registered.
Yeah. Okay.
Chair, so there's 24 votes for, 2 votes against, so the proposal is carried.
Okay, that's that dealt with. Okay, members. Just can I take a proposer and seconder to note a correspondence from the EA, and we can revisit that. Thank you, Councillor Coyle and Councillor Rennie, for proposing and seconding, and that's agreed. Urgent business, Councillor Green and Councillor Coyle. Obviously, both of you will have to be very brief, so I have to try and figure out where is Councillor Green. Okay.
Thank you, Chair. No, I wanted to raise the Breukborough Tempo GP surgery that has handed in their contract again. This is an extremely worrying situation for a lot of people in the area. This, I believe, is about 8,000 or 9,000 patients. So it takes in a big catchment area. It's one of the biggest in Fermanagh. I would suspect only Maple was a bigger practice, but I'm not sure on that. So when I heard this first of the rumours, I did email the powers that be to ask to clarify, was it true, firstly, and then to seek to see had the went down every avenue to see could this GP surgery be saved. As of yet, I have got no reply on that. So I would be proposing tonight that we do the same as we did with the Maple Health Group and look for an urgent meeting with the ones that control this, Department of Health, Western Thrush, HSC, whichever is the most relevant.
Is it that SPPG, isn't it? Yeah.
Yeah, well, whoever is the contract's handed back into, is it them that is handed back to?
Clarify, Alison.
Chair, the department, they will receive the contract. SPPG is the commissioning agent on behalf of the department.
Right, well, them and have a meeting arranged with them as soon as possible, because as we've seen with the Maple Health Group, they can get all sorts of rumours and all sorts of things out there, and again, there's a lot of honourable people, a lot of people in that practice that need clarity as soon as possible. So that's my proposal.
Okay.
Chair.
Thank you. I have to go to Councillor Coyle now.
Thanks, Chair. Mine isn't quite as serious, but I felt I needed to bring it up tonight because the deadline for this is before our next meeting. So I've been contacted by quite a few community groups that are quite frustrated as the council grants have only been open. They're only open for 18 days. Most community groups, which are usually run by volunteers, have to organise meetings to put together programmes, and these are going to have to be done outside maybe of their scheduled meetings and towards the end of the financial year, which is not going to be easy for many groups. So that means that some groups are going to miss out on this really important funding that the council funding is great, but a window of 18 days is just not really long enough. I know Mid-Ulster opens theirs for about 6 weeks. I'm not asking for that, but I am proposing that we look at maybe an extra week to 10 days at least, so that groups can properly prepare, meet, and complete the application forms and go for the grants, or go for all the grants that they're.
Thank you, Councillor Coyle. What I'm going to do is, because Councillor Warrington was due next in a sequence of speakers, the meeting's just running out of time. Are you able to second Councillor Green's proposal? Yeah, thanks very much for that. I know, but the time's out. I'm being advised by the Chief Executive that we'll be outside the time of the meeting. Okay, so Victor has seconded that, and you have seconded Councillor Coyle's proposal. Okay,
yeah,
is that agreed, members? Both agreed? Thanks very much. Okay, Councillor Feely has seconded.